So I'm going to ask you if you would refrain from reading your testimony because that would just be redundant. If you can capsulize it, I'm going to ask you to self-impose a like 2 to 3 minute limit on your input. If you can give us your best elevator speech, and then if someone has said what you wish to say already, just say I concur with so-so and or ditto. And with that, we'll begin. We have 3 of our colleagues who need to get on to their committees, so I'm going to start with Representative Oropeza. Welcome to the stand.
Thank you very much, Mr. Chair and committee. I greatly appreciate having the opportunity to testify today in person. So I come to you as a healthcare provider, but also a legislator in my background. I am a nurse practitioner as well as a gastroenterology nurse practitioner, to be specific. So I was contacted by the Alzheimer's Disease Association, given some statistics in regards to Wyandotte County, which is an area I represent, and was very taken back by the 13% of Alzheimer's, the highest population of the state of Kansas. So in saying that, it made me think of a lot of things being a healthcare provider. The head and the gut are very much connected, and when one is having stress, it definitely ends up in your gut in many ways. And so what I find myself doing for daily care and with GI patients in general is telling those healthcare providers to take time for themselves and to take self-care and to have that. In addition to that, some of the main complaints is I don't have the support, I don't have the money, I can't afford additional help or to leave my loved one with someone else. So why I'm here is because of the respite care services that are potentially being added to the SGF that would allow caregivers to have that much needed break. And it is a small number, but I think it's a very worthwhile number and will be used to help those caregivers to keep those patients in the home longer. I'm hoping you'll hear from additional people of how that is so important given dementia and Alzheimer's to not disrupt their daily living from day to day and to really keep a continuation of care and with loved ones so they feel safe and secure. I did provide a lot of data, so I'm hoping you do look at that. And if there's any additional questions, please let me know. I can even answer via email. But that is why I'm here today, to truly support that and doing something great for those healthcare providers or those stay-at-home caregivers that will provide something for their loved ones and keep them out of institutions. Thank you.
Thank you, Representative. Let's check and see if there are any questions from the committee. Any questions for Representative Oropeza? Seeing none, thank you.
Thank you.
Next, we have Representative Titus. Welcome, sir.
Thank you, Mr. Chairman and members of the committee. I appreciate the opportunity to come before you today. In my testimony, you will see a draft of a budget proviso that I'm asking for adoption of in the KDAD's budget this year. And what this proviso would do, it would be a funding for a 1-year study that would examine involuntary discharges and transfers from state-licensed adult care facilities. So assisted living would be the shorthand you're probably most familiar with of those facilities. But this bill comes from a constituent issue that I had. My predecessor, Representative Highland, actually started a bill last term to try and provide rights of appeal when somebody is involuntarily removed from a facility. Those only exist in federally regulated facilities, not in state-only licensed facilities. His bill did not move forward. I had a bill that would have been similar in Judiciary Committee that passed committee but did not get above the line last year. And looking at this issue, what I've realized is that we don't have good data on how often this is happening. The only time state agencies see this is if there's a complaint filed, which is a small number of the discharges that occur. So this study would allow us to spend a year, find out how many happen in a year, find out how many of them are actually emergencies. It wouldn't be personalized data. It would just be sort of generic and would provide a report back to us so that I can work with stakeholders and determine if any further studies or any further appeal rights are necessary. I did work with facility owners, profit, nonprofit, and the advocates for providing better care, and everybody's in agreement that this is a good approach to look at the issue. So I'd certainly appreciate your support and stand for any questions.
Thank you, Representative. Questions for Representative Titus? Just a quick one. To summarize, it's a $75,000 one-time ask, and it funds a study.
Correct.
That is it. Okay. Committee, other questions? Having none, thank you. Next, we'll call Representative Howell. Welcome.
Let's see. Thank you, Chair Mason and members of the committee. I just want to thank you guys for the opportunity to address the $40 million housing grant that the governor included in her recommended budget. You know, over this last year, I have chosen to invest probably several hundred hours of my life into understanding and researching the topic of homelessness in the state of Kansas. And as I have done that, it has become abundantly clear that there is a real lack of funding sources available to use specifically for shelter infrastructure for the homeless, and it is causing real problems across many of the counties and cities across our state. So because of that knowledge and issue, I just wanted to bring to the committee's attention that I have chosen to create a bill, which is House Bill 2723, which is expected to have a hearing in welfare reform very shortly. And this is addressing that $40 million and putting the focus more on homeless infrastructure. And it is a, again, one-time ask. It's a matching dollar grant with the local government. And it has a number of provisions that would require some wraparound services, collecting HMIS data. The wraparound services are for Kansas residents, enforcing local encampment and vagrancy laws, along with a clawback commitment to the state for that one-time investment. So I just wanted to encourage you to kind of keep that in mind as you're considering the $40 million housing grant from the governor's budget, and I look forward to having more conversations with you about this topic. And I stand for questions.
Thank you very much, Representative. Questions for Representative Howell? Representative Barth.
Thank you, Chairman Mason and Representative Howell. Nice to see you here. Can you give us an idea of the infrastructure is a very broad term, and can you give us an idea of the utilization of this, where it would be utilized with the $40 million? We've heard a little bit from the agency, but still there wasn't much clarification for the money.
Well, in regards to particularly with my bill, what we're talking about is actually homeless shelter infrastructure. So it is like the preliminary where they would come in off the streets when we're not going to allow them to be in encampments anymore. They have to come to the shelter and receive services. So it's the first stop to getting that help. So we're talking about a physical structure. It could be maybe an expansion of an existing structure. I will just say this. I have talked to dozens of counties across Kansas, and I do not believe I have heard yet from one of them that they have enough shelter beds. So I think all of us agree that encampments are not a safe option for anyone, no one in the community, the environment, or the unhoused themselves.
Is there, as a follow-up, is there any money in here to help us address other states and people bringing homeless people to the state of Kansas thinking we're going to fund their homeless population?
Yes, this bill actually specifically addresses that we will provide long-term care, long-term wraparound services for Kansas residents and people that have been in residence in Kansas for 8 months.
Representative Hobson.
Thank you, Mr. Chairman, and thank you, Representative. Just like you said, this is a one-time ask. Is that correct?
Absolutely.
Now, is there a coalition that's being formed in the area that we're talking, like, you know, when I say coalition, between local entities in regards to some of the services that are going to be provided?
Absolutely.
Could you speak about that, please?
Absolutely. Over the summer and fall, there has been in our particular region that I represent, we have had meetings with our City of Wichita, Sedgwick County Commission, and area bipartisan meetings with the Republican and Democrat electeds, all meeting together to, along with our nonprofits and all those government agencies that we're working together as a team to make sure we have an effective program.
Right. So in other words, follow up, please. With respect to the local agent, they're going to provide some of the services as well. I mean, with respect to some of the healthcare and transportation, that's on the local
Yes.
level. Is that correct?
That is correct. So local government and agencies will be providing the actual care and the ongoing budget. The state is only being asked for the infrastructure one time and none of the operating costs.
Because I know that was initially it was a confusion. This was like a program, which is but this is
Right.
only a one-time. Okay, thank you very much. That's all I have.
Thank you.
Representative Clifford is monitoring online, and he has a question. Representative? Representative Clifford, can you hear me? Okay, we'll get back to him. Committee, are there other questions? Representative Ballard.
Thank you. Hi, Lee. How are you?
Hey.
I'm looking at this, though, and I guess I'm not sure what exactly your ask is. It starts off by saying, the governor 40 million, but what's actually your ask?
So my ask actually is just asking you to have an awareness of my bill and the issues that I'm covering in that bill. The needs I'm wanting to address specifically are the shelter infrastructure for the homeless, but just have an awareness and be prepared to support and protect those funds for that use.
I wanted to make sure because I don't want to just say, well, I think that's what she's saying, but that's what it was. Thank you so much. Appreciate it. Thank you, Mr. Chair.
Representative Clifford, are you with us? I guess not. Thank you, Representative. Next, we'll call Jamie Gideon with Alzheimer's Association.
Mr. Chairman, can you hear me now? It's Dr. Clifford.
Oh,
There he is.
yes. Yes.
I'm very sorry. I think the question was asked by Representative Ballard, so I'm good. Thank you.
Okay, we're ready for you, Representative. Oh, is he passing? Okay. All right. Jamie, I'm sorry for that delay.
Good afternoon, Chair Mason and committee. My name is Jamie Gideon. I'm the Kansas Director of Public Policy for the Alzheimer's Association. First of all, I want to thank you all. Many of you were able to meet with our advocates last week as a part of our Advocacy Day, so definitely appreciate that. I know they enjoyed speaking with you about our legislative priorities, so appreciate that. In Kansas, there are 85,000 caregivers that are taking care of their loved ones with Alzheimer's, and they need your help. Most of them don't take care of themselves because they're taking care of their loved ones. They have a higher incidence of depression and other health issues, again, because they're taking care of their loved ones and not themselves. And many of them actually pass away before their loved ones because they're taking care of them over their own self. So we're requesting relief for these Kansas caregivers who provide this essential care by giving them access to respite care. Respite care is a service that gives a caregiver a break from caregiving duties. And under this proposal, caregivers can be reimbursed for up to $1,000 for things like adult daycare, home health, and equipment needs. Family caregiving relief will ease the burden, enhance quality of life, and reduce the number of persons with dementia who are prematurely or unnecessarily placed in a long-term setting. We hope that by delaying or preventing long-term care, that this will help reduce workforce issues and help reduce state costs. Therefore, we're requesting $600,000 in SGF for respite care funding, with 10% of that going to the area agencies on aging towards administrative costs because they will be administering the funds. Thank you. I'm happy to take any questions.
Very well, thank you. Committee questions for Jamie? Seeing none. Thank you so much.
Thank you.
Wait a minute, Jamie, hang on just a second. I'm sorry. I'm getting a notification that Representative Clifford's hand is up. Representative Clifford, are you with us?
Yes, can you hear me now?
We can.
Yes, is this, we already heard about respite care. Is this similar to what was expressed before by the representative from Wyandotte?
Oh, yes, she was speaking in support of our ask.
Thank you.
Thank you, Jamie. Next, we'll call Leah Kaufman with Shatterproof.
Good afternoon. Put my notes here. Good afternoon, Chair Mason, Vice Chair Carpenter, members of the committee. Thank you so much for allowing me to testify today. My name is Leah Kaufman, and I'm the Assistant Vice President of Public Policy at Shatterproof. We are a national nonprofit organization dedicated to addressing the disease of addiction. Our organization was founded in 2013. Our founder and CEO, Gary Mendel, unfortunately lost his son to substance use disorder. It's a story that's unfortunately very familiar to a lot of people. They had gone through 8 different treatment programs over a period of 10 years, and his son ultimately lost his life. Addiction is obviously not new, but it's a constantly emerging crisis. As we've seen the last few years with fentanyl, and the worsening mental health crisis post-pandemic, many individuals have been turning to pills that they think are prescription Percocet, Xanax, and Adderall, and end up overdosing because they have deadly amounts of fentanyl in them. We at Shatterproof, we focus on 3 core areas. First and foremost, we are working on transforming the treatment system to ensure that individuals are able to navigate to high-quality addiction treatment. Right now, there's not a good, transparent way to do that. Kansas has a 988 crisis line that I will commend KDADS for doing a wonderful job implementing, but not all people are comfortable picking up the phone to seek help. So at Shatterproof, we've created treatmentatlas.org. It's an online addiction treatment locator that's now being used in 14 states, including your neighbors in Oklahoma. And it includes validated information on treatment facilities in the state, the services they offer, helps connect people in special populations such as veterans, pregnant women, adolescents. And so people don't have to go on Google anymore when they're looking for care. We also focus on stigma reduction and on educating and empowering communities on the disease of addiction. We have prevention, treatment, and recovery resources. So I guess I'm here today urging you to support the funding of a statewide addiction treatment locator in the amount of $275,000 in the KDADS budget. The treatment locator includes not just a front end for the public, but an analytics, and on the back end, the agency and others using it would be able to identify gaps in care across the state. So there are outcome measures included. You can look at where there may be a lack of services, where there are higher performing facilities or lower performing facilities, and then allocate resources as needed. And 700 people overdosed in Kansas last year, so there's an urgent need for this resource. Thank you so much. I'm happy to answer questions.
Committee, what questions do you have for Leah? Representative Barth?
Thanks, Chairman Mason. Is this already in the budget that we heard specifically? Do you know or do you recall? It's not. This is an additional ask then, right? Okay.
Correct.
And so I have a question then about the statewide treatment locator that you mentioned. Is this a new product? If so, who's the developer of the product?
Yeah, absolutely. So it is not a new product. It was initially launched by my organization. We're a national nonprofit. We have staff all across the country. And in 2020, we launched it in 6 states. It's now available in 14. And it's also, a lot of those states are using it in different ways, but it's intended to be integrated with existing resources like 988 crisis lines. Right now, there are only helplines people can call. There's not like a transparent database of services.
To check it out.
So it is treatmentatlas.org. And if you wanted to look at it, I'd recommend search. You can type in your city and state. Go ahead and use Tulsa or Oklahoma City, since they're nearby. Yes, absolutely.
Representative Clifford, you have your hand up. Representative? That sounds promising.
No.
Did you say no?
No, I do not. Sorry.
All right. Oh, Leah, so the 275,000, is that a one-time ask to get the platform up off the ground, or is that like an annualized thing?
Yeah, so it's a one-time ask to get the platform off the ground, and we intend to continue to pursue opioid settlement funds to sustain it.
Okay.
It takes 9 to 12 months to build and implement, though, so we understand those funds through the settlement won't be available. Yeah, we want to get it going, I guess, is what I'm saying.
Committee, other questions? Seeing none, thank you.
Thank you very much for your time.
Next, we have, I'm not going to try to pronounce the last name because I will botch it. So it's Courtney from Valley Hope Foundation. I'll let her say it.
All right. Good afternoon. My name is Courtney Pear. On behalf of everyone at Valley Hope, thank you, Chairman Mason, for this opportunity to testify and answer questions related to our Bridge to Recovery Capital fundraising campaign. We're requesting state assistance in the amount of $2.5 million for an expansion and renovation of our Atchison facility. Valley Hope is a nonprofit drug and alcohol addiction treatment organization and was founded in Northwest Kansas in 1967 and now operates 17 facilities in 6 states. 6 of these locations are in Kansas. Valley Hope restores lives affected by addiction and supports lifelong recovery. We know the value of continuing care and ongoing support of this chronic disease. The purpose of the campaign is to alleviate overcrowding. In our 52 years of service to Atchison, we've completed 4 small modifications in an effort to address the patient and staff overcrowding. The Bridge to Recovery Capital fundraising campaign is the long-term solution, adding 28,000 square feet to our campus. The project is budgeted at $6.8 million. We view the campaign as a public and private partnership. To date, we've secured $2 million in private donations. Senator Pat Roberts, our honorary campaign chairperson, hosted Governor Kelly in our Atchison location recently, and the governor acknowledged the value of public and private partnerships and urged us to work with the legislature. This campaign is really only a reality with state support. Chairman Mason, Vice Chairman Carpenter, Ranking Member Ballard, and the members of the committee, thank you again for the opportunity to be here today on behalf of Valley Hope. As you consider priorities worthy of state assistance, we respectfully ask for your support in this effort. The decision to pursue state and federal partnership was not made lightly. In fact, this is our first time in our 56-year history that we have approached the state in this manner. Thank you again for your time and consideration, and I'm happy to answer any questions you might have.
And again, this would be a one-time ask.
One time, yes.
Committee questions. Representative Ballard.
Thank you, and this is for a variety of things, but mostly addiction, am I correct?
Our primary treatment is for those with a diagnosis of addiction to drug and alcohol. We do provide co-occurring treatment to those who have a co-occurring diagnosis of a mental health disorder as well.
And you said something about expansion and renovation, just a little bit.
Sure. So there was a building adjacent to our campus that we were able to purchase. It was a school that had closed down, so we would need to renovate that facility, and we'll create that into a clinical care center where patients will spend their day. It also has a gymnasium, so they can also have indoor recreation activity. Once that Phase 1 is completed, we will be doing a renovation of our another part of our campus to expand our nursing station and detoxification area as well.
Thank you for clarification.
Of course.
Committee, other questions? Seeing none. Thank you, Courtney.
Thank you so much.
Next up, Sean Sullivan, Midland Care.
Thank you, Chairman Mason. Members of the committee, my name is Sean Sullivan. I'm the CEO of Midland Care. We provide several service lines to the community, primarily to older adults. What I'm here to talk about this afternoon is the Program of All-Inclusive Care for the Elderly, or PACE for short. I want to assume that everybody knows what PACE is. It's still a relatively small program in Kansas, but there are 3 PACE providers. The first is Ascension Living, and serving Sedgwick County as a catchment area, has a PACE center in Wichita. The second is Blue Stem Communities, that has a PACE center in Hutchins-McPherson, serving 7 rural counties. The third is Midland Care PACE. We serve 12 counties in Northeast Kansas with PACE centers in Topeka, Lawrence, KC, and Emporia, and we'll be adding one in Olathe next year, and we'll be adding Johnson, Miami, and Franklin counties to our catchment area, actually March 1. All 3 of us, particularly Midland, are seeing significant increase in the demand for the program because of its outcomes, because of who it serves, and that is people that are 55 and older, people that are certified by the state to need nursing home care, and those that are determined to be able to live safely at home with our assistance when they enroll in the program. What we provide as PACE providers are all primary care, preventative care, medications, therapy, home care, transportation, social activities, meals, et cetera. Essentially whatever's needed to keep them at home and out of a premature placement in a nursing home. We contract out acute care, nursing home care, and specialists to those in our network. And through what's provided, the model is successful in keeping 95% of those that we serve at home where they want to be. The PACE program is funded 99% through Medicaid. 99% of the people we serve are on Medicaid. 80% of the people we serve are also on Medicare. And we are here to ask for consideration with our PACE Medicaid rates. And the way that our PACE Medicaid rates are set is the state, primarily KDADS and KDG, determines with their actuarial assistance, firm assistance, here's what we'd be paying the CanCare managed care companies if these clients were not in PACE. And then, so they set that rate, determine what that rate is for CanCare, and they take 10% off, and that's what they pay the PACE providers for the Medicaid rate, or that's supposed to be the target. Over time, ends up being a greater discount than the 10%, but that has always been kind of the state target, at least for the last 10 or 12 years. Our ask is that we are brought up, or what's called rebased, back to 90% of the amount that the state would otherwise pay if our clients were not in PACE. My testimony has the estimate on that, which is I inserted $1.9 million for state fiscal year 2025. That was based on our own internal estimates between the 3 PACE programs. KDADS believe we'll be sending updated estimates over to KLRD today, tomorrow, or if they haven't already. And I believe that will go from 1.9 to 2.4 million SGF to compensate for the growth that they have in caseloads. So, Mr. Chair, thank you for your time. Happy to answer any questions if there are any.
Thank you, Sean. Committee, questions? Not seeing any. Thank you. Next up, Matt Johnston, Maxim Healthcare. Welcome.
Thank you very much, Chairman, committee members. My name is Matt Johnston. I'm the Director of Business Operations for Maxim Healthcare. We are a home and community-based service provider in the state of Kansas that specializes in what's called specialized medical care, also known as private duty nursing. This care is provided through the TA waiver and the IDD waivers under home and community-based services. This service provides in-home nursing by an RN or an LPN to take care of the most severely injured and chronically ill patients in our communities. I'm here to ask the committee to increase the reimbursement rate from $47 to $55 per hour. That would estimate out to be about $3.4 million in SGF, and that would be continual funds. This was requested in the KDAD's budget, but was not adopted into the governor's budget. The $47 that we're at right now is reflective of the advocacy that was done starting back in 2017 and 2018. Obviously, over the past 6 years, we've had significant changes in that, mainly being, a COVID pandemic and changing the way that nurses are being compensated. The big thing is this is an all-inclusive rate as well. This isn't just for our nurses that are servicing in the home. This is for the gloves, the hand sanitizer, the protections, workers' comp, liability insurance. This is an all-inclusive rate. So as we continue to fund this more and more, the drive is to continually have that balance between both the nurses and the ability to impact the community at a greater level. Over the past few years, as we have seen support from the legislature, which is very much appreciative to get us to the $47 rate, what we've seen is still having to use at a significant level single case agreements. What these are the MCOs determining on a single basis whether every patient, a certain patient is eligible for higher reimbursement. This is not a sustainable model. So the reason why we're asking for this increase would be make sure that we can run as efficiently and effectively as possible, because single case agreements are a backlog for the MCO, the state, and the provider network. To give you an idea of some of the cost savings that you would see within this, as the comparison for this service or the facility equivalent is an acute care hospital. A week of services for home and community base, or what we're providing at the increased rate, would be around $3,000. The facility equivalent of a NICU in Children's Mercy would be $63,000. That is a delta of $60,000 per week if they're in the hospital, opposed to if they were in home. This is the most vulnerable population in our state. The struggles that these patients and these families face every single day are real, and most of us can't even possibly fathom it. What these families have to go do, simply going to the grocery store, is almost incomprehensible, because they have to load up almost their entire house to make sure that their loved one is taken care of being away from the home. It's simply daunting what they go through all the time. So any relief that we would be able to give them is imperative. So once again, my ask is to increase that reimbursement rate from $47 to $55. I will, there's further details in my testimony, and I'll stand for questions.
Thank you, Matt. Committee, do you have questions for Matt? Seeing none. Thank you.
Thank you very much.
Next, I would call Des Martins from Mirror. Welcome to committee.
Thank you, Chairman Mason and committee. I'm Des Martins, President and CEO of Mirror. In a recent conversation I had with a friend and the CEO of a hospital, she asked me a question. Do people who suffer with addiction ever really get better? You see, her view was seeing people in and out of the ER over and over, but my answer to that is yes, they do. We see it many times. Adam was born in a family deep entrenched in drug abuse, and at just 10 years old, Adam was addicted to meth. Adam Kabulis is an example of a life touched by every line of service Mirror provides. Our reentry services out of prison, addiction treatment services, and our Workforce Success program that provides job skills, life skills, and parenting skills. Chairman Mason, may I ask Adam to stand briefly? May I ask Adam to stand briefly? Today, Adam is a remarkable man, a loving father, determined to give his boys a better life. Adam is a valued Mirror employee who just received a promotion and completed his training as a certified peer mentor. Adam was instrumental in starting an Oxford House for families in Topeka. He works to make a difference for families, communities, and clients every day. Thank you, Adam. At Mirror, many of our strongest, most passionate clients are leaders, are people in recovery. We believe that whatever happened in your past, you can still build a beautiful future. Mirror is the state's largest provider of addiction treatment services for the uninsured, the underinsured, and justice-involved Kansans, as well as Kansans enrolled in Medicaid. We are often the last best hope for vulnerable Kansans. We offer treatment programs in the counties I've listed, 11 counties, in person, treatment. We also offer telehealth services and medication-assisted treatment around the state of Kansas. In FY23, we provided 4,803 Kansans with services. And as you see the funding breakdown for that, we've got 27% funded through the block grant, 16% through the state opioid response grant, 12% through Medicaid, and 12 from Senate Bill 123, which are justice-involved clients, 10% through grants, and just 2% have commercial health insurance. I want to take a moment to join Behavioral Health Association of Kansas and KDAD's in their ask for $5 million. We agree. We join in with the ask you will hear later for $5 million added to the block grant. And thank you for that last year. My ask is a bit different, and I'll move into that, or another ask. For MIRROR, the additional funds is helpful to resolving a larger problem with funding. Commercial insurance companies pay between $500 to $550 a day for residential treatment. The current block grant rate, state opioid response rate, Senate Bill 123 rate is $198 a day. Medicaid rate is $206 a day. Our cost per day for providing services is between $175 and $200. So the costs continue to increase with inflation, with reimbursement rates for services rise much slower. Private pay commercial-based treatment providers and organizations that receive enhanced reimbursement rates offer salaries that are $10,000 to $15,000 higher than what we can pay at MIRROR. With wages provided by others that are that much higher, we are disproportionately impacted by the workforce issues. We are losing clinicians and other key staff who report loving their jobs, but they can't stay at MIRROR because they need to support their families. We lost 25 clinicians in 2023, and just last week we lost 3. Within MIRROR's existing facilities, we have the capacity to operate 203 residential treatment beds. And due almost entirely to workforce shortages among clinicians, we currently only operate 140. We have wait lists in those beds of 4 to 6 weeks for adult males, 8 to 10 weeks for adult females. We have 30 to 40 on the wait list for each residential location and 60 for our outpatient. If MIRROR were able to provide comparable salaries to recruit and retain our clinicians, we could offer up to 740 additional 28-day stays for Kansans we serve, for a total of 20,720 residential days. We respectfully request that $2.4 million be allocated to MIRROR in fiscal year 25 for a workforce project that will assist us in recruiting and retaining staff by enhancing salaries, expanding training opportunities, funding continuing education and growth opportunities, and supporting practicum students and interns on their path to licensure. Funding would ensure that MIRROR could continue to deliver high-quality treatment to vulnerable Kansans. Thank you for your time and consideration of our request, and I will stand for questions.
Committee, questions for Des. Representative Barth.
Thank you, Chairman Mason. Just a quick question. Do patients have trouble finding you at all, or do you have a wait list? And then my second part of that question is, have you heard of Shatterproof that was presenting earlier, and does that fit into your model, having that as a system out there potentially to help?
We have an assessment center in the Wichita location we have referral sources all over the state. We're pretty well linked and connected to like RADAC and parole, and we have plenty of referrals and plenty of people coming in need of services. So it's just that wait, and when we know that, I think someone else mentioned the overdose deaths, the overdose rates in Kansas. When a person has to wait that long, they're ready for treatment and they have to wait. That's the challenge. And Shatterproof, I am not familiar with, and I don't know if our Vice President of Treatment is familiar with that. No, we're not.
Representative Clifford, I see your hand is up.
Chairman, thank you for your presentation, Martin. Wondering what kind of success have you had in applying to the opioid settlement fund?
Yes, we have. The way that's set up is they put out small grants the first cycle of that, of the first year that came out. We did apply for that and received a couple of grants to help us. I think the total might have been $200,000 that we received to Part of that was to put in a fire suppression system so we could add reintegration beds to one of our locations. And then one was to enhance our medication-assisted treatment. So, you know, we have to have a medical director and trained nurses to deliver medication.
Thank you. Thank you, Mr. Chairman.
Thank you.
Representative Ballard?
Thank you, Mr. Chairman. All right, I'm looking at, thank you so much for being here today. I'm looking at your list of, all right, so you can operate 140 beds, but you have the capacity for 2,003. The wait list, 4 to 6 for males, 8 to 10 for females. How would you advertise if you should have this money? Because if I'm reading between the lines, workforce shortage, you can't find people to work, especially at the rate that this is, okay? How will you get these people there?
To work for us or clients?
The people to work so
Okay.
that you can eliminate that waiting list.
Right. First, we want to retain the people we have, because that's been an issue for us. The people we have that love their jobs are offered higher salaries and need the income. So retaining our current people. And then we also want to prioritize promoting from within and providing training for the people we currently have to step up like we have. We already do a lot of that. We want to grow that. And honestly, we see a lot of applications and we make a lot of offers, but when it comes down to the salary, they say no. So we don't feel like this would be real difficult.
You did a great job answering. Thank you.
Thank you.
Mr. Chair.
Committee, any other questions? Seeing none. Thank you, Des.
Thank you.
Next up, we have Audrey Schremer from Three Rivers. Welcome to committee.
Thank you, Chair, committee members. I will be very brief. You have my testimony on behalf of the Kansas Centers for Independent Living. We would like to request support for the waiver waiting lists. Of course, that's been a hot topic for quite a few years. But I also would like to speak up for rate parity for the Medicaid waivers, particularly in our self-directed programs for which the centers continue to advocate. There is as much as a $2 an hour difference in waiver reimbursements, and that is seriously impacting individuals' abilities to get direct service workers. Just due to circumstances, people on the head injury waiver, brain injury waiver, and the physical disability waiver now are reimbursed at the lowest rate. And that can be asking people to work for $9 to $11 an hour, and that's not cutting it. So we ask for your support for rate parity. And that is all that I have. Thank you.
Thank you. Committee questions? Seeing none. Thank you. That brings up Stacy Chandler. Welcome to committee.
Thank you, Honorable Chair and members of the committee, for the opportunity to speak to you today about my dream job. My name is Stacy Chandler, and I've received disability service for 20 years. Over the past 2 decades, I've gone through many ups and downs with my various jobs. I have worked many communities-based jobs, and almost everyone left me feel defeated. I went through being treated poorly by my coworkers and customers, as well as being made me feel that I was not good enough. I enjoyed my longest community job at Threatovia the most, but it still wasn't my dream job. I started working in a workshop in 2020, and it's truly my dream job. The things that are important to me that this job provides are working with my peers and friends, staying up to date about current events with my service provider, having flexibility to stay encouraged with my community, and making great money that helps me pay my bills and have fun. People sometimes describe my work as segregation, but I am not anything but segregated. I live in an apartment in the community right in the center of town. My location helps me easily go local community events. I volunteer in local organization and a member of a Kiwanis Club. I have spent a lot of my life with people telling me what I should and shouldn't do. The same goes for employment. People keep trying to encourage me to try a normal job again when I have no desire to do so. There is not one road to success, and I have found the one that's brought me success I want. However, I have a lot of friends who haven't landed their dream job yet and may want to try working in a community. As a capable person who has worked in the community, I struggle. I know that my peers who are interested in trying it will lead a lot of support. I appreciate your willingness to increase funding so my peers can find their own dream job like I have. As you move forward on making a decision that impacts services for people with disabilities, please always try to take time to speak and listen to us. Thank you. I will stand now for question.
Thank you, Stacy.
Thank you. Have a great day. Oh, I'm sorry.
No problem. Committee, are there questions for Stacy? Let's just check and see if there are. You did a great job. Thank you.
Thank you.
Next is Roxy Holton and Sheila Brimes. Are they coming up together? Is that my understanding? Okay. Okay.
Rough day, and she didn't want to be here. So this is my daughter. I'm sorry. I'm not going to be as elegant a speaker as the ones before me, but I will try to make it quick and brief. We're talking about job opportunities for the disabled. So I'd like to give just a little bit of background about her livelihood. About her. She was born deaf and legally blind. She had enough vision that she was a happy-go-lucky child, enjoying life like everybody else. At the age of 11, she got an eye infection. Her vision was wiped out overnight. So she went through a very deep depression for about 2 years. When she finally got back to school, she was at the deaf school in Kansas City, and the teachers there were not trained on blind skills. So they transferred her to the deaf school. The problem here is that those teachers were not knowledgeable about sign language, let alone the tactile signing that she needs. So her communication went downhill. Her last year of school, we were fortunate enough to meet a woman named Sally. She became Sheila's intervener. For those of you who are not familiar with that term, an intervener does more than an interpreter. Interpreters strictly mimic conversations. An intervener is somebody who lets her know what's going on in her surroundings, helps her in whatever need she needs help, as well as facilitate communication. So therefore, Sally became Sheila's Annie Sullivan. She was so impressed with Sheila's skills that once she finished school, she had connections enough to get Sheila to work at KU Med Center in this sterilization unit. The interveners, because of their job, they get paid double to triple what Sheila's hourly salary was. So, I'm sorry. Sheila worked 5 40-hour week, which was a very long week for her. So she was very relieved when the Helen Keller Center in New York called to see if she could come up there for training. So needless to say that KU could not hold Sheila's job for a year. And when we moved to Ottawa, we had a family friend who owned Subway. So he hired her there, but also now a coworker has to lay the food out on a shelf in a sequence to be used. She has to then label the pans with the date and the type of food that's going to go in each pan. And then she has to stack them so that as Sheila goes and gets the food out of the cooler, she opens it and she puts the food in the particular pan, and then she puts a lid on it and walks it back into the cooler again on another shelf for later use. But this job only took about 2 hours a day. So in both these jobs, she was not without help from others. and because of her dual disability, she will never be completely on her own. The level of support that is needed is both extensive and expensive. So each individual has her own unique capabilities and personalities. Sheila gets a sense of belonging, support, and a feeling of achievement with the current work on her piece rate work. And the examples of this is that 3 women in our family have worked on planes. So when I tell Sheila that she is putting protective sleeves on plane screws, then that makes her feel like she's doing what the rest of her family did. When she folds boxes for computer components, well, that's important also because her dad works on computers. So she was fortunate to get the chance to work in the mainstream jobs, but they were long and tedious for her, so it wasn't her thing. And the amount of support to accommodate for these individuals is more costly than allowing them to work at the workshops. So companies are always looking for ways to save money, so they're not real thrilled about that. One company's already moved their contract overseas, putting people here out of jobs. So please do not take away their purpose of feeling like a productive part of society. Okay, thank you. I'm trying not to take too long. Okay. So please don't take away their purpose for feeling like a productive part of society and their livelihood. Also, please consider that in order to increase community-based employment options, there needs to be a significant investment in the support and funding available to make this possible. Thank you so much for your time.
Any questions for Roxanne?
Yes.
Representative Ballard.
I'm sorry, what?
Since I interrupted you, I'm going to say something to you. Do you feel better now?
Yes, thank you.
And your main purpose was do not take. Tell us again what your really ask is.
Is that you consider funding for people with disabilities so they can stay in the workshop, that don't take away the workshop work because it's not slave labor.
Yeah,
it's important work to them.
There you go. Thank you so much.
Thank you for your time.
Representative Barth.
Chairman Mason, I just want to say hello. I don't live in Ottawa, but I have part of Franklin County in the district, so I appreciate you coming and speaking on behalf of your daughter and for the community as well, so thank you for that.
Thank you very much.
And thank you for being an advocate for your daughter. And I think there are people probably in this room who could help too. So I'm just going out on a limb here and saying that. Next, we'll call Shelley May, Johnson County Developmental Supports.
Thank you, Chairman, members of the committee. I'm here to talk to you about employment also. So my name's Shelley May. I've been in the field of IDD services in Kansas for over 35 years, and I've talked a lot about employment. I currently work for Johnson County Developmental Supports. I'm the deputy director there, and we serve over 600 people in the Johnson County area. One of the programs we provide is day and employment services, and we serve over 300 people in those programs. About 150 are engaged in integrated competitive employment. And so they average that they work is 18 hours a week, and they earn $12.85 an hour. On average, it's good for the people we support, it's good for business, and it's good for our community. Investing in employment is a win-win-win, just all the way around. Like I said, I've been in the field a long time talking about employment, and that conversation always leads to funding and reimbursement methodology that we use for support employment. And in my testimony, I provided some examples of currently, the rate is $17.88 an hour. The governor put in her budget for a raise to $28 an hour. We start our employment staff around $22.73 an hour. So just kind of do the math there. It doesn't really cover benefits or training, onboarding, certification, all the administrative tasks that it takes to provide a quality service. So we're asking that you would consider more of $50 an hour to cover all the administrative costs to provide a quality program. I've also put in my testimony our revenue and expenses and our employment services for JCDS, and annually, we lose about over $100,000 just to provide the service. And so our board believes in it. We believe in it. We're going to keep doing it. In Johnson County, there's 87 affiliates who provide IDD services to provide employment, and that's why. And so if you want to move the needle on employment, you know, we've got to raise the rate and change the methodology for billing. I provided a story of somebody that we support in my testimony, but there's also a QR code on the back. Shows a lot more stories of people we support, and they're out there working. So I invite you to look at that when you have a moment. But thank you for your time and your consideration, and I'm happy to answer any questions.
Let's check and see. Committee, questions for Shelley? Seeing none.
All right, thank you so much. I appreciate it.
Next, we'll hear from Marvin Miller, a parent. Welcome, sir.
Thank you. Good afternoon. Thank you, Chair Mason. I'm going to talk as Lily's dad. I'm a parent. I'm a dad. I'm here to talk about the IDD waiver, and I won't read my testimony here, but she's 21 now, almost 22, and right now we don't have access to the supports and services that she needs. I know she got to meet Representative Carpenter a couple days ago as I was trying to navigate this Capitol with her in her wheelchair. We still have high hopes for our daughter, but she has some seizure disorders now and other medical issues, but we still believe that she is a valuable God-imaged person that has laughter and gifts for our entire community. We've been on the wait list 10 years and 3 months. So this is my concern. You know, once you hit 21 and you don't have those services available, you just kind of drop off a cliff, and we have to scramble trying to figure out what to do with her and where to go, especially if she has a caregiver that's sick. We pay out of our pocket all of her SSI money plus more just to try to fund some caregivers, which is still probably $1,000 less than what day programs would be if we were able to pay out of pocket, but we can't do that. In the past year, we've watched her regress. You know, during a transition program in school, she learned how to self-advocate for herself. She helped out the Union Rescue Mission in Wichita, helping serve food and stuff like that. But now she isn't around her peers. She doesn't have those opportunities. A waiver would help fund a day program that could help her get out into the community, be with peers, socialize, volunteer with different organizations, maybe even help with getting braided funding with other things, with job coaching and voc rehab and transportation, so that maybe she could find one of these jobs that hardly do exist where she could maybe make 10 or 15 hours a week. So I'm asking as a parent, please let's reduce this wait list. We have, I think, 5,400 some people on the IDD wait list, and there's other wait lists that we're waiting for funding too out across Kansas. Like I said, we've been on it for 10 years. We thought when we got her on in 5th grade we'd have enough time to see this. So thank you for continuing to fund and expanding your funding. I appreciate it. I'll stand for any questions.
Okay, committee questions from Mr. Miller. I'm not seeing any. I might have a quick one. Your daughter's been on for 10 years and 3 months.
Correct.
When you ask about that, what kind of an answer do you receive? Why it's been so long?
Well, the issue is that really no expanded funding has been given in the last 5 or 6 years in any of the budgets from the governor's office. I know that they made an amendment, I think, to this budget to add a few more hundred positions. That will, maybe get us on, but it'll still leave another 5,000 people waiting 10 years. So, but it's time to take care of it. So, thank you.
No argument here. Committee, other questions?
Thank you.
Thank you, sir. Now, I know I'm going to botch this one. I'm going to try it, though. I'm going to call Laura Pinkapank. Please correct me.
Better than most, yeah, all right. Okay, so my name is Laura Pinky Pank, and I am actually here with Marvin to ask for additional funding for the IDD waiver. So my story is a little bit different than Marvin's story. My son, Jack, is 20 years old today, and he was diagnosed with autism, ADHD, OCD, anxiety, apraxia, mental retardation, epilepsy, as well as scoliosis when he was 2.5 years old. At that time, I did apply for the waiver, and when he was 12 years old, so about 9 to 10 years later, he did qualify for the waiver. So we've been on the waiver for 8 years now. And I can tell you that the waiver makes a huge difference to our family. When I first applied for services, I was in an entry-level position and barely making ends meet because my son was constantly getting kicked out of daycare because he doesn't belong there. He needed one-on-one services, which I couldn't afford. Since being on the waiver, I've been able to promote up into a director role at my office. We've been able to expand our family and have another son. We've been able to join a church, do community service. I've been able to sleep at night because we have somebody who's there to help watch Jack. In addition to all of this, Jack is going to be aging out of school in the next 1.5 years. And there are so many services in Johnson County where I live where you can't even get a day service unless you have the waiver. And so we're very fortunate because we've been able to get on wait lists so Jack can go to a day service so we can continue to work after he ages out of school. However, that's not the case for everyone, like Marvin. So I just want to come here today to share my story and talk about how much the waiver does help families out there. And especially to thank you as well for providing the funding that we've had over the past 8 years. That's made a huge difference for our family. And that's it. Open for questions.
Committee, questions for Laura? Seeing none. Thank you
All
so
right,
much.
thank you.
Next up, Catherine Meinhardt.
Thank you, Chairman and members of the committee. My name is Catherine Meinhardt. I am a foster and adoptive parent and the CEO of Dream Makers here in Topeka. I want to thank you for the opportunity. I'm currently parenting 8 children from the Kansas foster care system from all ages and stages. They've all suffered different levels of prenatal exposure and resulting in fetal alcohol spectrum disorders. I can offer a small glimpse into the trials and struggles. In 2012, my son moved into my home at age 7, unable to read. We would sit there at night and he would sound out the words in hop on pop. Tall, ball, wall, turn the page, and he couldn't recognize any of them because his brain wouldn't have the ability and didn't have the capacity. It was a different background, therefore it was a different context. Now, he turned 18 last year, and unfortunately, I didn't even hear about the IDD waiver list until he was turning 18. So now he's at 19. He has static encephalopathy, a brain that functions that of about an 8 or 9-year-old. He has the desire, like his peers, to move on and move out, but no ability for independent living. He needs supportive services every day, personal care, and so much more. I also have a 6-year-old who many days can't recognize that his pants are pants or how to put on a shirt just to get ready for school. These boys aren't alone. FASD affects 1 in 20 children. That was pre-COVID known numbers, and now we know binge drinking went on the rise over 40% during COVID. We've got a crisis. I'm now also parenting a 13-year-old that's currently in foster care, and she's developmentally delayed, wheelchair dependent with spastic quadriplegic CP. She has 24/7 care needs. She needs to be on an IDD waiver, and I can't get a worker to complete paperwork. She fully relies on us for her toileting, diapering, lifting, transfer, meals, personal care, bathing, you name it. All of these services would be addressed if and when she gets onto the wait list once I get paperwork completed by a caseworker. I strongly believe it's crucial for our state to prioritize funding for and remove this wait list. We need to ensure that individuals with IDD have timely access to services and the supports they need. I am the founder and CEO of Dream Makers. We're an FASD community for young adults like my son. We're the only community in the country that provides supported living and on-site job opportunities for adults living with an FASD, allowing a sense of normalcy for each and every one of these individuals. I want to let you know that this is investment parenting, and as a community, we can either invest now and provide services for individuals, or they're at a high risk for things like human trafficking, for gang activity, for homelessness, and incarceration. So if we don't pay up front, we're going to pay later in the other systems. Over 80% of people in our prison systems have an unidentified FASD. Kansas families like mine really cannot afford to wait any longer. So we ask that you all step up and invest in our IDD community. Invest in that wait list. Our family supports the Kansas Council on Developmental Disabilities request to reduce the wait list by 20% in this year's budget. But furthermore, I move that you work to eliminate it so that we can make the lives of many Kansans much brighter and better. Thank you for your time, and I'll stand for questions.
Committee questions for Catherine? Seeing none, thank you.
Thank you very much.
That brings up Dr. Courtney Sullivan. Welcome, doctor.
Thank you. Thank you very much for the opportunity to submit testimony, like the other wonderful parents, for funding intellectual IDD waitlist. As a parent, I strongly believe that it's crucial for our state to prioritize funding for the waitlist to ensure individuals with IDD have timely access to the services and support they need. I appreciate you listening to my brief testimony. My daughter, Celeste, 16, wasn't diagnosed with autism spectrum disorder, intellectual impairment, intellectual disability until she was almost 15 years old. For years, she was misdiagnosed. Finally, in 6th grade, she was seeing a counselor who mentioned that she might have autism. There was a huge list for her, a huge wait for her to get psychological testing. But unfortunately, in April of 2020, the psychologist canceled due to COVID, and my daughter had to wait 2 more years to get the diagnosis. Due to all the delays, my daughter did not get on the IDD wait list until about a year ago at 15. I got a phone message from the CDO a few months ago saying that she was off the wait list. When I called back and spoke to the woman who left the message, she said she had called me by mistake. I believe she said that the wait list is now 12 years long. I cannot express how upsetting this was to me to find out that I thought my daughter was finally going to get the help. But not only was she not going to get help for which she qualifies, she may be waiting for over 10 to 12 years. That means she'll be age 16 or 26 to 28. I worry so much what would happen to her if I were to die or to suffer some serious health issues or lose my job. According to her psychological evaluation, she's always going to need help with grocery shopping, nutritious food preparation, transportation, money management, and legal issues, which is why the IDD waiver supports are so vitally important. It's hard enough as a parent to hear that your child is disabled, but it's devastating to hear that she cannot be helped because the wait list is too long. I'm so upset by this, I can barely find the words. It's inconceivable to me that in what the most vulnerable in our state, in which is what the richest country in the world, and their families are being told to fend for themselves because there's just not enough to help them. As we've heard before, how many of these folks with disabilities end up on the streets, turn to drugs, end up trafficked or in jail? Kansas families like mine cannot afford to wait any longer. This is not about big government discouraging folks from pulling themselves up by their bootstraps. It's about some of the most vulnerable members of the community who need help gaining independence, and sadly, advocates who'll make sure they're not being exploited. It's about families who need some extra support so they can remain active in the workforce. The state has a budget surplus of $2.7 billion and a rainy day fund of $1.4 billion. And some of you, maybe not you here, hopefully not, have already forwarded demands for tax cuts to the governor. Yet you choose not to help the 5,400 families who legally qualify for aid. And I just wonder how you can look at parents such as myself or these other lovely people in the eyes and tell us that our beloved children are just not a priority for you. The very least you could do would reduce the wait list by 20% this year's budget, and then hopefully 100% soon enough. Thank you.
Thank you. Are there questions for the doctor committee? Seeing none. Thank you for appearing. Next up, Sean Gatewood, CanCare Advocates Network. Welcome, Andy.
Good afternoon, guys. Thanks for taking time. Last but not least for me, Chairman Mason, committee members, I proudly serve as the supervisor at Envision's contact center in Wichita. As somebody that's been predominantly legally blind for the better part of 3 decades, I understand the profound challenges people seek in employment and independent living for a world that's primarily designed for the sighted. My career path has not been that simple. I started to lose my vision at a young age, not knowing what my future held and job opportunities most importantly. Despite this, I secured a job at T-Mobile where I successfully worked for about 10 years until they changed their software programs and they became inaccessible. It was at this time that they let me go. This was a pivotal time in my life, and thankfully in 2012, I was introduced to Envision and all they had to offer, not only to low vision, but many lives of other backgrounds. Envision recognized, thankfully, my capabilities, gave me some comprehensive computer training, and I have moved up in almost now coming up 12 years to a leadership role where I can pay it forward now. Envision's more than just employment. It's a nexus of opportunity, determination, by pioneering programs in fields such as the culinary arts, cybersecurity, and digital skills to those with vision impairments. Through our Workforce Innovation Center, Rehabilitation Clinic, and other programs, Envision creates pathways to meaningful, competitive paid employment. In 2012, I had very little vision. In 2018, I lost all usable vision. Thankfully, Envision in 2015 made a major investment because of our executive board and board members. So now every job at Envision is accessible. I urge you to enable Envision to continue helping these people, not only with their programs, but these critical services we need to be prosperous and independent living. And I really appreciate your time today, and thank you.
Take a few questions, Andy.
Yeah.
Representative Barth.
Andy, hi, this is Representative Barth here. I remember you from last year, and I do recall that we did approve some budget for Envision last year, and I think it went through appropriations as well. So can you talk a little bit about how that helped you guys last year?
That is something my CEO, Michael Montifrani, will be able to approach. I know there were some different programs to help with our day program, so I believe that's where some of that did go to.
Thank you.
Committee, other questions for Andy? Representative Ballard.
Hello, Andy.
Hey, how's it going?
I do not have on the diagonal jacket, but I have a brown one that sparkles.
I like it. You're always well dressed. Very tactile for us blindies, you know.
Well, we have. We had this conversation out in the hallway. That's why last week, so I wanted to just remind him. I do have a serious question, though.
Please.
What is it that people really need to know about someone whose vision you had and you have lost?
That's very important. I mean, you look at somebody, you know, I'm very fortunate. I grew up in Wichita. My grandpa was an optometrist. I had other people that taught me, you know, look at somebody's, when you talk to them, shake their hands. And Envision happens to be where I grew up. So I'm very fortunate to have Envision right there. Envision does not just, here's a job, go work it, that's it. We have lots of different services and programs through Envision to help with upward mobility. We've had people with master's and bachelor degrees working on a factory line folding trash bags. Envision recognized that and very quickly made changes to where they can move through the company to white-collar jobs. It's very important. Not only are we trying to be a pinnacle part of what people see as a standard, but we do go out into the community and let people know, hey, we can do just about anything. I mean, I always joke around, but you know, if you're going to be blind, now's the time to do it. Technology is our friend. You know, if I didn't have, with my vision when I lost it, people would make fun of me, but I had to get rid of my BlackBerry, move to an iPhone, and it's very accessible. So not only is the world more accessible to blind people, we can do just about anything except drive. But that's, maybe with some AI and Tesla, we'll get there.
All right. Thank you, Andy, very much.
Thanks for your questions, ladies. I appreciate it.
Representative Clifford.
Thank you, Mr. Chairman. Hi, Andy. Welcome back. And,
Hey, thanks.
Admire your duty having to escort Miss Kansas around.
I did have some better art and candy. Now I'm just with a couple executive guys from work. That's,
Yeah.
She's a great ambassador and goes all over the state representing us way better than I can.
Yeah. No, you're a great ambassador.
Thank you.
Chairman or Andy, is there a specific ask to Envision? I don't have access to the written testimony right now, or will that come later? Thank you.
I think Representative, it will come later.
Yeah, yes, we will have.
Michael Monteferranti is in the queue here, but.
Good question, thank you.
Yes, it is a good.
And we heard you.
Any other questions for Andy? Okay, thank you, sir.
Hey, thanks for your time, guys.
Great to see you always.
Good to hear you as always.
Okay, now we'll get back to Sean Gatewood. Sean, welcome.
Thank you, Mr. Chairman, members of the committee. Appreciate the opportunity to testify today. That does not want to stay at my level. For the most part, we wanted to just say thank you. The governor's budget, as well as the years leading up to this. There's been a lot of investment in the last few years, and including this budget, and making the Medicaid system much more robust for Kansas, particularly those Kansas with disabilities, and we want to appreciate that. This budget has enhancements for drawing down the IDD and PD waiting list. We think that the state could probably go further than that. We want to appreciate what's there, but if you see fit to draw down that wait list even more. I got started in this, my college internship. Granted, I was a non-traditional student, but my internship was on ending the waiting list years ago. And here we are. And I think at that time, the wait list was 2,500, 3,000 people, something like that, and we're over 5,000 now. So getting those wait lists down is a high priority. Also, the supported employment stuff, that just gets our world into a more competitive, integrated environment that's just the right direction to go as we see it for those Kansas with disabilities and for the rest of us too. So I will stand for questions at the appropriate time, and thank you again for the opportunity.
Let's see if there are any committee questions. Seeing none. Thank you, Sean.
Thank you.
Now we're ready for Michael Monteferranti, CEO of Envision. Welcome, sir.
Chairman Wilson, Mason, thank you very much. Vice Chair Carpenter, good to be here with you. Ranking Member Ballard, thank you for the opportunity to share a few words today. You've got the written testimony. Thank you for taking time to review that. And a few things that Andy shared, no need to repeat today. So thank you for listening to the kind words that he's also had to share today. But at the end of the day, what Andy's shared is what we do. And he's a great example of that. And we've shared what Envision does through the years in multiple areas. And I'm here today to share two specific areas that we've not had the opportunity to talk to you about in the past. And one is workforce innovation, and the other is rehabilitation and services in regards to impact on programs. So we do provide great jobs, like Andy says, great benefits. We turn individuals that have disabilities and blindness and visual impairments, which are tax consumers, and we turn them into taxpayers. And that's why I'm here today, is to share with you how we want to continue to move that forward. We're a very sustainable not-for-profit. The investments that Envision is blessed with, we are a multiplier in regards to that. And so we have been around for 90 years in the state of Kansas, and in Wichita. We're expanding throughout the state and having impact. We talked a little bit about Miss Kansas, and she is actually representing all 105 counties, and she's at number 98 right now. So we're very proud of her impact that she's having around the state in regards to vision impairment. And what we're finding right now is more and more people are needing services. As you may know, in 2010, Kansas closed the Kansas Vocational Rehabilitation Center for the blind and visually impaired. And at that time, the budget was approximately $1 million, right? We are taking a lot of that on ourselves. We provide services to people who are blind and visually impaired, regardless of their ability to pay. Right now, the areas that we're talking about in the testimony are running at about a $1.2 million deficit. So the ask today is for $600,000 in order to help cut that deficit in half and for us to continue to move forward, impact more people, employ more people, and provide more services. So thank you for consideration today and your ongoing commitment to the health and wellness of all Kansans, and happy to answer any questions.
Very well. Committee, questions for Michael? Seeing none. Thank you. I just want to give our conferees a pat on the back. We're moving along very, very well. Thank you for that. Next up is Kyle Kessler. Welcome, Kyle.
Thank you, Mr. Chairman, members of the committee. I'm Kyle Kessler, Executive Director at the Association of Community Mental Health Centers of Kansas. We appreciate the opportunity to provide testimony and requests to the committee this afternoon. And I'll go ahead quickly through our three principal requests, the first being about the middle part of page 2 of our testimony, which is a request for 7 additional FTE for KDADs in the amount of $570,000, almost $571,000 in all funds, with half of that amount being from State General Fund. These are positions that are currently funded, but the grant runs out. They will help us, we believe, achieve a CCBHC demonstration through the federal government. So having that infrastructure available from a human resource standpoint will be helpful in that effort and the evaluation of the program as a whole. The second request I would make, which is on the back page, is relating to access to integrated health care for all Kansas communities. We have over half of Kansas counties that have no primary care safety net clinic in them, and several along the north central and south central parts of the state and state lines. And we would like to see $1.95 million in grants to help subsidize nurse practitioners or at least part-time primary care services and integrate those into our currently standing mental health center offices in those counties. The mental health centers have coverage across all 105 counties, and so believe we can help fill a gap that might exist there. And lastly, is a request on behalf of our Kansas Behavioral Health Center of Excellence, which we started working on about 6 months ago and has been actively meeting for over 3 months. It includes about 15 partners in the south central part of the state to start with. We believe this is a replicatable model and will help solve our workforce crisis in the mid and long terms. I believe there are several conferees after me that will be coming forward, and this is really partnerships beginning at the higher ed level, and then we also know that the workforce right now craves paid internships and practicums and fairly paid residencies. We believe that if we can value them early and often, then we have more ability to retain them here. Plus, in the south central part of the state, as you heard in your state hospital testimony on KDADs, the new mental health facility in south central Kansas is going to require substantial workforce as well in an area that is pretty workforce starved right now, and we believe is in crisis. So we believe we can really help with that in the next couple of years, and to that end, our request is for $5.4 million that would go towards programs at University of Kansas Med Center in Wichita, as well as Wichita State and some other partners. So, and that's outlined in the details of the testimony, and I will stand for questions at the appropriate time.
Committee, questions for Kyle. Representative Barth.
Thanks, Chairman Mason. Just a quick question about the physician shortages. Are you all utilizing any kind of virtual primary care at all?
Yeah, quite a bit.
helped
Well,
with that?
I think yes. And so there are a couple, and that's actually getting harder to achieve because so many other states are also going to it as well. So it's becoming pretty saturated, but in some ways, in fact, I heard a presentation on this at a national meeting yesterday in DC. You're starting to see more and more people staying out of the workforce and going towards doing televideo work as well. So striking that balance is kind of a challenge in our experience, but we would certainly use some additional primary care with the funding of the grants, and the televideo is probably more available with primary care physicians right now and nurse practitioners than those who specialize, psychiatrists and those who specialize.
All right, thank you.
Thank you, Representative.
Representative Ballard.
Thank you, Mr. Chairman. Kyle, we know that, I'm not sure, I wouldn't venture out to say all 50 states, but I would be pretty close, are having mental health services and workforce needs. Am I correct?
You are.
Okay. Now, if we talk about how we want to service or provide the services to the people, do we just not have these people anymore trained, or they were trained but they no longer want to do what they were doing before, and they can either make money doing something else? But what is really the problem that would affect all 50 states? Because COVID did something, but it was happening before COVID.
Yeah, and I think that one of the answers I would give, or part of the answer, is that we had the solution before. When we had the Menninger Clinic here in Kansas, which was in Topeka, then they moved to Houston, Texas, and took all of those training opportunities. They used to train literally 40 or 50 psychiatrists, psychologists, social workers, counselors, every year. And that workforce and that pipeline was rich in Kansas. So what we want to do with this Center of Excellence is really rebuild the Menninger Clinic in the aggregate. I've actually talked to Dr. Menninger, Dr. Walt Menninger, about this. And I mean, this is something that we think makes quite a bit of sense because the provider networks are pretty rich right now in Wichita. And so matching up the training opportunities from the academic side to the provider side, especially with the safety net, is fantastic opportunity to, and we don't want to just churn out workforce. We want to churn out high quality, well-trained workforce. So something that people will be proud of graduating from and taking into their professional lives.
I like that answer. It's encouraging. But the other thing is, I think it's truthful, because I think some people think that all of this happened as a result of just COVID. And I mean, COVID did its thing. But when we look at all of the things, especially in Kansas, we can't account for what other states do, but we must account for what we do in Kansas. And I think your answer says that maybe there is the workforce, but we're going to have to train and bring them along.
And I think out of chaos can come order. And I think between social media and the pandemic and things like that, young people have been subjected to more mental health crises than ever. And as a result of that, they are really comfortable talking about behavioral health. They're really interested in working in behavioral health. I saw a workforce panel when I was also in DC of young people, and I told them before I asked them a question, you all are going to make mental health cool again, or maybe cool for the first time, I don't know. But I mean, it's something that's very specific to what we can accomplish long-term with this.
Okay. Thank you very much. Thank you, Mr. Chairman.
Thank you, Representative.
Other questions? Seeing none. Thank you, Kyle.
Thank you, Mr. Chairman.
Next, it appears like we have a trio of doctors from KU Wichita via WebEx.
Yes, so I'm up first. My name is Rachel Brown. I'm going to say just a couple of words and then hand off to my colleague, Dr. Cassie Carlson, who's also here. So thank you so much for the opportunity to speak to you, and especially for the opportunity to speak to you virtually. One of the things I had not realized was how moved I would be by the testimony I heard today. I have been a physician and a psychiatrist and a child and adolescent psychiatrist, and have worked with people with autism and intellectual disabilities for most of my professional life, as well as with kids in the welfare system. And I am also a foster adoptive parent. And so listening to other people talk about the struggles and the challenges that they face, and also so impressed and humbled by the good work I've heard about from other professionals and provider groups who've testified today. So that was an unexpected benefit of being here. So let me say what I do. I am the chair of the Department of Psychiatry here at the KU School of Medicine in Wichita. I'm a physician. I went to medical school in London, and as part of my psychiatric education, I was trained at a place that specialized in providing clinical education, and knew of the other places across the world, including the Menninger Clinic, that provided the same kind of training as the place that I trained at. And I never expected that I would, at any point in my career, after working in 2 countries and 5 states, never in a place where there were sufficient psychiatrists, and especially not enough child and adolescent psychiatrists. I did not expect that I would end my career here in Wichita, Kansas, which has been a wonderful transition for me. So what we do as our little contribution to what's needed, and there's so many needs, what we do here at the University of Kansas School of Medicine in Wichita in our department is we train psychiatrists. So we train physicians. All of our medical students at the Wichita campus come through our department and spend time in a month or so with us, learning a little bit about our specialty. And then we take those graduating medical students, 6 every year, and they spend 4 years with us learning in depth and breadth about the human brain and about mental illness in all its presentations, in different age groups, different kinds of clinics and settings, including inpatients and outpatients and our community partners. And then they go on to practice in our community. More than 80% of the psychiatrists in South Central Kansas came through our training program. And now I'm going to hand it off to my wonderful colleague, Dr. Carlson.
Very well.
Hi, Chairman Mason and members of the committee. I am Dr. Cassie Carlson, and I am the Program Director of the Child and Adolescent Psychiatry Fellowship here at KU in Wichita. I really appreciate this opportunity to speak to you on the topic of child and adolescent mental health in the state of Kansas, and as part of the proposed Behavioral Health Center of Excellence. So as a physician who's board certified in psychiatry, child and adolescent psychiatry, and neuropsychiatry, I'm definitely honored to speak to you about this topic. And like Dr. Brown, very moved by the families and folks that have spoken today, very similar to many of the patients and families that I see in my practice. But I'll tell you, I'm most excited to speak to you as a fellow Kansan. So I grew up on a family farm in Harper County. So rural Kansas kids are kind of a soft spot for me. And, I really think that it's our responsibility to build something for this next generation of Kansans. We have an opportunity and a responsibility to meet the mental health needs of the state of Kansas, of the youth of the state of Kansas. So I will tell you, 2 years ago, I had the opportunity to move back to Kansas. I'd spent the previous 8 years on faculty at Indiana University, which is the largest medical school in the country. And I was also the program director for child psychiatry there. So when I learned that KU Wichita wanted to develop a child and adolescent psychiatry fellowship, I was really excited to move home. Child Psychiatry Fellowship trains physicians to become experts in child and adolescent mental health. I'm really proud to report that through philanthropy of private donors, organizations, and even some funds from the city and county, we were able to start our fellowship ahead of time and just welcomed 3 child psychiatry fellows for the first time this past July. So this is a pretty big accomplishment. In Kansas, we're a competitive bunch. I work for KU, I bleed purple, but I will tell you, we are not winning any national championships in child mental health here. And, when we look at how many child psychiatrists the state of Kansas needs to meet the need of our kids, we need about 400. We have fewer than 70, and all but about a dozen work in the northeast corner of the state. So that means we have only about a dozen child psychiatrists to serve the remainder of the state, the city of Wichita, the rest of western Kansas. And right now, Kansas, I heard questions earlier about, how's the rest of the country doing and how do we compare? And in a survey that came out in 2023, we actually were dead last in terms of our access to care. And workforce was one of the main reasons that we rank so low. I'm not going to kind of go over some of the statistics I think you guys have heard in terms of how dire our needs are. But I think to echo what's been said as well, this did not just start after the pandemic. We were not keeping pace prior to the pandemic. And the thing that we know is that 50% of adult mental illness starts before the age of 14 and 75% starts before the age of 24. So we really need to think about child mental health and child psychiatric care as preventative medicine that can help all of the things that folks have been testifying about today. So what we're looking to do is we want to train child and adolescent psychiatrists practicing in our state and delivering this highest level of care. A child and adolescent psychiatry fellowship is a 2-year program that you generally enter after 3 to 4 years of general psychiatry training. But our proposal is to fund a child and adolescent psychiatry integrated track where there would be 3 residents per year in a 5-year program. Training them right here in Wichita is really the only way to build our workforce. And evidence shows us that physicians across all specialties tend to take their first job at the place they train, right? So this is really where we can get physicians in our community working and taking care of our families and children. I was just going to say to end that building the Behavioral Health Center of Excellence in Wichita, Kansas, and investing in child and adolescent mental health is really investing in the next generations of Kansans. And I think really part of our commitment that we should leave things better than we found them. I also want to say kind of what Kyle just said is that, building a center of excellence implies we are planning to build the best. So we're prepared to offer state-of-the-art, evidence-based psychiatric care. The youth deserve that. And so being able to train and have them receive care from child and adolescent psychiatrists is so important to that. Thank you, and I'm available for questions.
Very well. Committee questions? Seeing none. Thank you for appearing.
Thank you for the opportunity. That was excellent. We really appreciate it.
Okay. Next, I would call Michael Countryman. Welcome, sir.
Thank you. Chair Mason and members of the committee, my name is Michael Countryman, and I'm the Chief Executive Officer for South Central Mental Health Counseling Center located in Butler County. I greatly appreciate the opportunity to testify in support of grant funding for the provisions of primary care services for underserved areas of Kansas, of which Butler County is one. If you're not familiar with South Central Mental Health, I'll briefly share some information about South Central. South Central Mental Health provides direct care services to approximately 3,500 consumers, of which 1,600 of those are children. 20% of the adults that we serve are considered severely mentally ill, and 21% of the children that we serve are considered severely emotionally impaired. On average, South Central Mental Health receives 3,000 crisis calls each year, and we also have providers in 20 schools across the county. However, in Butler County, one of the issues that we face is the lack of a primary care safety net. This causes a significant issue for individuals who are trying to get primary care. And currently, we do not have an FQHC, or often as federally qualified health center, located in Butler County. As a newly provisional certified behavioral health center, South Central Mental Health has a responsibility to coordinate and ensure all the care for our patients, and this includes access to primary care. As a county not served by a primary care safety net system, we're very aware of how difficult it can be when our patients need more primary care than we're able to provide. The CCBHC model is an integrated care approach, and we believe that CCBHCs may be able to fill some of the gaps that we currently have. As such, I respectfully ask that you support the $1.95 million for grants to CCBHC serving counties without an FQHC or an FQHC lookalike to provide primary care services. I do appreciate your time, and I will stand for questions.
Very well. Committee, do we have questions for Michael? Seeing none. Thank you.
Thank you very much.
Committee, it would be my preference to finish this today. Is there anyone who can't stick around? And is there anyone presenting who has to get on the road? You are? Well, you're next anyway. So I don't know why you're raising a fuss. You're next. Dr. Jessica Provines, yes.
Dr. Clifford, I'm going to stay online.
Mr. Chair, members of the committee, thank you for having me here today to speak on behalf of the Kansas Behavioral Health Center for Excellence policy priorities. My name is Dr. Jessica Provines, and I serve as the Assistant Vice President for Wellness and Chief Psychologist at Wichita State University. I work with our Student Wellness Center, and that means the areas that work with me are our student counseling, our student health services, and our health outreach, prevention, and education services, otherwise known as HOPE services. That's our population-based arm that focuses on early intervention and prevention to try and reduce some of the most negative impacts of behavioral health and suicide and overdose, of which we have seen a significant increase on our campus. So my journey at the university started 25 years ago as a first-generation college student. I transferred and quickly found myself isolated and alone and became clinically depressed. I had no idea there were quality mental health services available to me as a student because we didn't talk about mental health in the late 90s the way we are doing today. Representative Ballard, I think that has some impact on why we're seeing the crisis that we are today. It's just the increase in demand for people willing to seek help and get help because we've always had silent sufferers. I started my career as an unpaid practicum. At Wichita State, we provide training for social workers, counselors, psychologists, nurse practitioners, physician associates, and many of those, particularly behavioral health fields, their practicums are unpaid. We could attract more people to the workforce and have, if we could pay them, and have a more diverse workforce if we could pay them as well. I was drawn to working with some of the most suicidal patients and worked at Prairie View, one of our community mental health centers in the state, in our working with the most severely depressed and suicidal patients. When I came back to Wichita State University, I continued working with our severely depressed students, and sadly, I have lost 3 patients under my care to suicide, which is the reason why I keep doing what I'm doing. There have been times where our entire training program would have been closed if I would have followed my colleagues to higher paying jobs in the community, and then the pipeline would dry up. I served as a training director for our American Psychological Association accredited doctoral internship program, and in my tenure, I have seen South Central Mental Health close their psychology training program, ComCare close their psychology training program, the Child Guidance Center closed their psychology training program. Usually what happens is one person was hanging on, and then they retired, and then the whole thing shut down. I can't do that. I'm not going to let that happen on my watch, but it's exhausting and I'm tired. We need to support our academic training programs because people want to do these classes, but we can't accept everyone who's applying because we don't have the staff and we're not paying them a competitive wage for what they can make in the private practice. I really hope that you act on this now when the
state hospital opens, the crisis is just going to intensify, and we have an opportunity to fix that. We have a clinical psychology program at Wichita State. If we funded a fellowship and a specialty in forensic psychology, we could create a pipeline ensuring the essential function of providing those competency to stand trial evaluations are taken care of in our state, and we don't have the multiple years waiting of those in the criminal justice system. I believe that's all I wanted to share with you today. I appreciate you hearing my testimony. I hope that you act now. It's time.
Thank you, Dr.
Any questions?
Are there questions from the committee? Seeing none. Thank you, Doctor.
Thank you.
Next up, Lori Gonzalez, Ember Hope Youthville.
Chairman Mason, Vice Chair Carpenter, and Ranking Member Ballard, and other members of the committee, I want to thank you for the opportunity to take the time to speak, for me to speak with you about the impactful work we have been doing at our psychiatric residential treatment facility. I'm actually Allison Pate. I'm the Vice President of Residential Services for Ember Hope Youthville. And a few years ago, our agency came before you asking for funding for an innovative PRTF that would address specifically the concerns noted in the 2019 NRI report for the state of Kansas on the use of psychiatric residential treatment facilities. We cannot thank this committee or KDADS enough for taking a chance on that pilot, and I'm happy to report that that pilot has demonstrated positive results throughout the 3-year program. It is time for us to move from a pilot to having this be a regular practice in PRTFs as well as our PRTF. But in order to do that, we're asking for $500,000 of additional funding this year to cover aftercare and those services that are not currently covered in the standard PRTF rate. So some of those successes, I want to take a minute to talk about that. Over the 3 years we have been doing this, only one youth that we served readmitted to a PRTF in the year following their discharge. Only one youth did not return home to their parent or legal guardian, and only 2 additional youth entered Department for Children and Family Custody in the 6-month aftercare program. We believe that the biggest affirmation of the positive impacts of our program are the youth we serve. And I have a young lady here with me today, Addison, that I would like to give her the opportunity to speak about her experience, and then Addison and I would be happy to stand for questions.
Welcome.
Hello, my name is Addison, and December 17th, 2021 was the day my life began to spiral out of control. Following a high school breakup, I began to feel like I was worthless, hopeless, and all alone in a world that nobody wanted me in. My dark and depressing thoughts overpowered me to the point that I began feeling like everyone around me would be better off if I wasn't there. These thoughts quickly turned into vocal warnings and then worse. Over the next 11 months, my mental health continued to rapidly decrease to the point where I was failing classes in school, stealing money from loved ones, physically hurting family members, and running away, sometimes as many as 5 in one day. I'd isolated myself from my friends and had alienated myself from my family, truly believing they didn't care anyways. I experienced 5 short-term psychiatric hospitalizations, and though they kept me safe from myself from 3 to 5 days, I was never there long enough to figure out what was causing the problem in the first place. On November 14th, 2022, my parents sat me down with one of my therapists that was coming to our house twice a week for in-home therapy and told me that there was an opening at a psychiatric residential treatment facility in Newton called Ember Hope, and that they wanted me to go there. At first, I felt rejected by them, but that feeling went away as they pulled up the website and showed me pictures and explained more about it. My mom said that it was started by a United Methodist Church and that our United Methodist men's group at our church supported it. I began to come around to the idea, especially when I saw that the list of different types of therapies included dance therapy and equine therapy. I knew in my heart something desperately needed to change, so I agreed to go voluntarily. And on November 16th, 2022, my little brother's 9th birthday, my family dropped me off at my cottage and said their tearful goodbyes. What I didn't realize at the time was that the work that would take place through Ember Hope wasn't going to be me and me alone. My family was involved in my therapy twice a week for family night and family therapy. This made me realize that the feeling of being alone, all alone and unloved were just in my head and couldn't be farther from the truth. I began to see an improvement in myself as I experienced trauma-informed therapy with staff that were easily to open up and be honest with. I learned my trigger warning signs and coping skills to calm myself. Our family learned the importance of positive communication skills and how to recognize triggers and what to do to de-escalate the situation. I was able to continue to go to school and actually able to work at my own pace and make up classes I had failed. One of the other things that helped me at Ember Hope was that my spiritual life was nurtured in many ways. I received a couple care packages from my youth group at home, but I also had access to Bible studies and Sunday morning church services. After 4.5 months, I was discharged from care on March 30th, 2023, and I returned home as a whole new person, and just in time to get tickets to my junior prom. One of the services provided by Ember Hope was a 6-month aftercare program. My aftercare specialist, Lydia, was there for me as if she was a lifelong friend. She texted me and checked up on me. She came to our house and met with my family and I to make sure things were still moving in the right direction. She was just a phone call away from myself and my parents. We knew if we had any issues come up, she would be right there. She supported me with issues at school, finding a job, and even after I was discharged from this service, she still made the trip to McPherson to watch me give my testimony at my home church on a Sunday morning. My mom told me that when they first checked into PRTF care, they were told there was a minimum of a 6-month-long or more waiting list to every single facility in McPherson or in Kansas. However, I can stand here today and tell you that my God didn't find that good enough, because 3 days later, my mom got a call from Ember Hope saying they had an opening available immediately, and it was ours if we wanted it. That was the day God and Ember Hope saved my life. After all the support I received from my family, friends, and Ember Hope, I'm happy to say that I will be graduating on time with my class this May, and have been accepted to Barton Community College, where I will begin my educational path in pursuit of my associate's degree in arts with an emphasis in social work, with a goal to finish out a bachelor's degree at Kansas Wesleyan University. My dream would be to return to Ember Hope in a different position, with the ability to help others with my own story on my side. Thank you.
Committee, do we have questions for either? Representative Hobson.
Thank you, Mr. Chairman. You're asking for $500,000, is that correct? Is this a one-time funding, or is this, what is?
So it will be annually until the regulations for the psychiatric residential treatment facilities are able to be changed. I know that is the intention of KDADS. So that the services are reimbursable. Currently, aftercare is not reimbursable. We have a parent cottage on campus that serves both youth in child welfare and in the custody of their parents, that they can stay on campus if they need to. We also have a parent peer support position that is available, and none of those are currently reimbursable through the Medicaid rate with the state of Kansas.
Thank you, Mr. Chairman.
Committee, other questions? Representative Ballard.
Yes, I think our audience clapped for you, but for those of us sitting here, we'd like to say congratulations, because the way you started out and how you ended, that was you working with other people to do that. So the best of you.
Thank you both for being with us. Thank you. We're going to change things up a little bit. We have a conferee who needs to leave in about 10 minutes, so I'm going to call Mark Schulte on WebEx. Mark?
Mr. Chairman and members of the committee, thank you for the opportunity to provide and thank you for the flexibility to let me testify. To testify for the budget request, the funds for nursing facility reimbursement program. I've submitted written testimony, but want to start with just thanking the committee for fully funding nursing facility reimbursement program in the fiscal year 23 and 24, and for supporting KDAD's fiscal year 25 budget for nursing facility program. Again, my name is Mark Schulte. I'm the legislative co-chair for the Kansas Adult Care Executives. CASE is a nonpartisan, nonprofit professional association serving nursing home administrators and assisted living operators in Kansas. CASE members are located in all 105 Kansas counties in Kansas and represent state licensed only and CMS licensed adult care homes. One of our requests is to provide the Medicaid add-on for fiscal year 25. Residents who receive Medicaid continue to represent a larger percentage of those being cared for in Kansas communities throughout Kansas. Medicaid reimbursement dollars do not cover the cost of care in long-term care facilities. To make up for that shortfall, residents who pay privately experience higher rates to make up for that shortfall, or providers will lose money each day they provide care for Medicaid residents. The proposed fiscal year 25 budget, the daily reimbursement rates is slightly more than it was compared to the current fiscal year 24 daily reimbursement rates, which we are grateful for. But the daily rates from FY24 also had a Medicaid add-on that meant providers will actually receive less in FY25 to care for the same residents they're caring for now. And certainly we can, I think, expect that there will be increased costs in FY25. CASE strongly requests the legislature provide funding for the Medicaid add-on again in FY25 to cover the rising cost of providing care to Kansas elders. We have one other request, home and community-based services funding for Medicaid for frail and elderly. We appreciate that rates were increased for FY23 and 24. The waiver has not received an increase prior to that for many years. The FE waiver makes it possible for Kansas living in assisted living, residential care facilities, home plus facilities, and even receiving care in their own homes that would otherwise be provided in a nursing care facility. Providing care in those facilities or in a home compared to a nursing facilities is significantly more cost effective than providing care in nursing facilities. We're asking that the FE waiver funding is increased 3 to 5% to help providers keep pace with the costs incurred to care for those residents. The bottom line is failure to fund these kinds of programs fully are likely going to end up, and we've seen much of this in the last 10 years, more providers, especially in rural counties, needing to close their doors or go into receivership. Receivership is considerably more expensive to Kansas budgets than it is to increase funding to help those facilities stay open. Those facilities that are closing are resulting in rural Kansas elderly people having to go outside of their homes to find services because they're no longer available in the counties in which they live. Again, I appreciate for the support we have gotten in years past. We ask that to keep pace with the rising costs of the care that we provide.
that you'll consider the request we're asking for, and I'll stand by for any questions. Thank you for this opportunity today.
Thank you, Mark. We'll see if there are some questions. Committee? Seeing none. Thank you for sticking with us. Next person I'll call he has quite a ways to drive tonight, so I'm going to call Greg Kelly with Phoenix Home Care. Greg, welcome.
Thank you, Chairman and member of the committee. My name is Greg Kelly. I'm the partner and vice president of operations with Phoenix Home Care and Hospice. Phoenix Home Care and Hospice is the largest home health care provider in Kansas and Missouri. In Kansas, we have offices in Wichita, Hutchinson, Topeka, and Overland Park. We hope to have many more in the future. What I want to talk to you today is about having a strong home and community-based services program with particular emphasis on the FE waiver, the frail and elderly waiver. FE waiver provides Kansas seniors an alternative to nursing home care. It includes personal care, household tasks, and health services. It's based around promoting independence within the community and offer residency in the most integrated environment. Right now, at the top end of the billing codes, the reimbursement is around $20 an hour. Missouri has seen a huge cost savings with increases in funding to the home and community-based services programs. It's put Missouri at the bottom 3 of nursing home admissions per capita, where Kansas is in the top 3 of nursing home admissions per capita by population. Part of the success of the strength of the program in Missouri has been funding increases over the last couple of years. In fiscal year 23, we had a large increase to $30.52 an hour. In fiscal year 24, it was increased again to $32 an hour. So we, again, have more hours of cost-efficient care being delivered with these funding increases. At Phoenix, we were able to substantiate that with some true data. So from July through December of 2022, we averaged 9,733 weekly hours of care delivered in Missouri for the comparable program. We ended 2023 with 13,746 weekly hours of care being delivered. So that's a 40% growth in hours delivered. Meanwhile, in Kansas, the daily Medicaid reimbursement rate for nursing homes based upon the average of 293 listed facilities is around $280 a day. And so by increasing the FE reimbursement, we'll be able to keep more Kansas seniors out of nursing homes, which is better for them and the local communities. A senior may only need 5 to 10 hours a week to maintain their independence, to maintain living in the comfort of their own home and community. So this does lead to a positive impact on rural healthcare access as well as employment. We've seen rural nursing facilities close in recent years. And so that doesn't mean that seniors can't still gain access to nursing homes. They just have to go to a larger, more populated urban city for that care. So then they're displaced from their local community. So increasing the funding for the FE waiver will have a positive impact on rural health care access and employment. So to summarize, the ask is increasing the FE waiver reimbursement to $30 an hour or greater. It'll allow providers to deliver upon providing a more cost-effective alternative to long-term care placement, and it'll allow Kansas seniors to age in place in the comfort of their own home and community. I'm available for questions.
Committee, questions for Greg? Seeing none. Safe travels back home.
Thank you.
Okay, we'll get back on schedule here, committee, and we'll call Jessica Lucas, representing the City of Liberal.
Thank you, Chairman. If I may, Commissioner Ryan Beatty is online with Sedgwick County and has his son's basketball game at 6 p.m. So if I can defer to him, which is on the same topic that I will touch for Liberal, I would ask your permission to do that. Okay, Ryan, if you're online, you can go.
Very kind. Thank you. Thank you, Chair and committee members. And if I miss that basketball game, I'm going to be in a lot of trouble. So I certainly appreciate it. I'll try to be brief. I'm here to advocate and support the governor's placement of homeless funds for a matching grant in her recommended budget. And also to advocate for what Representative Leah Howe was in a short time ago to talk about her bill, HB 2723. I'm the chairman of the Sedgwick County Board of Commissions, and what you're seeing in this community is not unique from what other communities across the state are experiencing. And that really is that the homeless populations and homeless services are overrunning many of the services that we have in our communities. It's a growing crisis, not just in Wichita and Sedgwick County, it's a growing crisis around Kansas. And there's a lot that's at stake. I'll just share just a few things as to what really is at stake. And it's more than just the optics. I do think the optics matter. I think it's difficult to see so many people in our community in full public view that are in crisis, but it's more than optics. We have a safety concern, a public safety concern. These individuals that are unhoused are vulnerable. They're vulnerable to those that are trafficking. They're vulnerable to drug dealers. And I think we have an emphasis that we need to act to defend some of these vulnerable people because it's exasperating their crisis. But it's not just the safety of those that are unhoused, it's also the safety of our residents in our community. Not all, but some of these individuals that are unhoused are there because of mental health and substance use. And the drugs that are influencing some of these outcomes are different than the drugs 4, 5, 6 years ago and beyond. The methamphetamine and the synthetic drugs are actually inducing psychosis and creating an incredible volatile situation where we've had incidents recently in the city of Wichita to where we've had residents that have been attacked. So safety is a concern. Economics is a concern. We have over $700 million of deals in the pipeline in downtown Wichita alone. We're having a hard time keeping some businesses and attracting new businesses to downtown Wichita, primarily because of the encampment issues and the growing crisis of homelessness. You kindly at the legislature have helped to invest into a biomed campus coming to downtown Wichita. It's a $300 million generational project that will be placed right in an area to where we are struggling mightily with homeless encampments and our homeless population. So the business community down here is demanding progress. Sedgwick County represents about 20% of the economic output for the state, and we need to deliver some progress for our business community and our residents. The third thing, and then I'll wrap up, is it's becoming a significant cost to our taxpayers. Those that are experiencing homelessness are typically high utilizers of public services. Think about fire, think about police, EMS, even the county jail systems, but also to our medical systems, Via Christi, St. Joe, and the hospital systems down here. The homeless populations are driving up costs with our local public services, and there are better ways that we can invest into shelters so that we can connect them to the services they need to become stable and become independent of these government services. So I would just finish by saying that if this is from Sedgwick County government, it's a plea for partnership. We're asking for shared leadership in this. We're not asking the state to help with operations. We're not asking for any dollars in services. Those things we can do on a local level. What we're asking for is help with the capacity for shelter. The shelter is the most underfunded piece of the entire homeless ecosystem. And there's only a handful of shelters all throughout the state. Many of them are seasonal shelters. So we have a plea for partnership, a plea for shared leadership. And we believe that if we're going to make strides in the behavioral health piece of this state and our communities, that we cannot leave homelessness out of that equation. So I'm happy to stand for questions. I apologize I cannot be there in person, but I appreciate you allowing me to provide testimony on behalf of the Sedgwick County Board of Commission.
We do have some questions. Representative Barth.
Thank you, Chairman Mason. This is questions for you, Ryan, if you could stay on. You mentioned some things around some of the homeless folks that are doing things that are illegal, such as the use of drugs and attacking people. Are those folks being arrested, put in jail? What's happening with those individuals?
Let me first say that is not a complete description of all homeless people. It certainly is not. Not every homeless person is committing crimes. Not every homeless person is there because of substance use, but a growing percentage of our population is there because of substance use. And the type of substance use is inducing a psychosis. If you talk to medical experts and our sheriff, he would confirm that. But yes, the city of Wichita and our Sedgwick County Sheriff, when people commit crimes, they are being arrested for their crimes. But I certainly don't want to give a perception that all homeless people are committing crimes or all homeless people are criminals, because that would not be accurate. But the safety for them and for our community certainly is being compromised if we allow this crisis to continue.
All right. So I think you said that you are arresting those folks then. Is that?
Yeah, people that commit crimes in our community are being arrested.
I get that not everybody is like that. Just, I wanted to make sure that was clear.
Yes, thank you.
Committee, other questions? Thank you, Ryan.
Hey, thank you. Appreciate everyone there.
Yeah, good luck on the game.
Thank you, Representative Ballard.
Jessica?
Thank you, Mr. Chairman. So as a follow to that, I offer, for the record, Jessica Lucas with Watkins Public Strategies on behalf of the City of Liberal. I'm going to speak to all of you in regard to the City of Liberal's view on the $40 million in the budget. And then if you will, my colleague Jason Watkins is not able to be here at this time, and he's on the agenda for the Wichita Regional Chamber of Commerce, so I will speak to that as well. I think the City of Liberal is a unique perspective in regard to these dollars, because it shows that this is not just a South Central Kansas issue. And for them, it's a much smaller amount that they are seeking, but this infrastructure fund would be really beneficial to them. They have a shelter that desperately needs a kitchen expansion to a commercial kitchen. They're using crock pots and roasters and just not functioning the way that you would hope to be able to function to feed the community. The shelter is a 40-bed shelter, but is currently at 20 occupants because of some staffing capacity issues, but would look to use this money for commercial kitchen expansion as well as HVAC and roof repairs. So I just wanted to offer that for you. For them, they're thrilled that these dollars are available and would make a big difference for them as they work to address the homeless population in their community. To pivot then to the Wichita Regional Chamber of Commerce, in your handouts there are several pieces of testimony from our business community. As Commissioner Beatty mentioned, the Wichita Regional community, this is a business issue, and we've had several conversations at the Wichita Chamber with our members about what homelessness means in the downtown core, and we're seeing it spread through other parts of the city, and the community desperately wants solutions. What the City of Wichita and the county have been working on is something that we are behind and feel is the right approach, and that is why we're standing up here in support of the investment of $40 million. Whether that remains in the KDED's budget or another part of the budget, we're agnostic to that, but we certainly do hope to see those resources come through the process. And with that, I'm happy to answer questions on behalf of either of those clients.
Committee questions for Jessica?
Thank you so much.
So we'll treat Jason Watkins as written only then?
Yes, the Wichita Chamber I've covered, and the rest of their good words you can read.
Very well. Okay, pep talk time. We're doing good. Let's just keep going. Okay. Colin Olenek. Welcome, Colin. If you need to move that microphone down, feel free to do so.
Okay, I am you push me up a bit. My name is Colin Olenek. I work for the Self-Advocate Coalition of Kansas as their legislative liaison, or it's called SAC for short. We are a member of the Big Tent Coalition, which is a combination of disability advocacy groups. And so I will just echo some of what JCDS, Johnson County Developmental Sports, and I believe that doctor that was here. And I would just suggest to you that the governor's budget amendment is in terms of slots for both PD and IDD services is inadequate. We at the coalition suggest 1,100 slots for the intellectual and developmental disability services waiver, and about 500 for the PD waiver. I would also associate my comments with those who suggested a dollar amount of $50 reimbursement for supported employment. And so I will stand for questions now, I guess.
Very well, Colin. Committee questions? Seeing none. Thank you for appearing. Next up, Stuart Little. Welcome, Stuart.
Thank you, Mr. Chairman, members of the committee. I can read the room. Okay. I'm here on behalf of the Behavioral Health Association of Kansas. It's an organization of substance use disorder behavioral health treatment providers around the state. The list of the members are on the back side of the page. So we are an organization of not-for-profit groups around the state that do drug and alcohol treatment. And we are, first of all, we're recipients, not just us, but you all last year added $6 million into the funding pool to treat drug and alcohol services. And greatly appreciated. And we're coming back this year to ask for those $5 million again to have consider doing that. It was requested by KDADS. The governor did not recommend it. And we're asking you to consider some addition to the funding. And I'll tell you who this is for. Exactly the people you were just talking about when we were talking about homelessness. They're not Medicaid eligible. They can't have insurance. They have to be below 200% poverty, and they can get drug and alcohol treatment. There's a federal block of money that comes to the state, and we add state money in, and so that makes the pool, and then it's allocated among providers to do drug and alcohol treatment, and they're positioned around the state to be geographic coverage and all those kind of things. So we're asking that if you all have the capacity, these dollars will go to fund those folks that otherwise don't have a funding source, who are part of, in many instances, are part of the population that we're talking about with the unhoused. And I would appreciate your consideration when the time comes. I'd be happy to answer questions.
Committee, questions for Stuart? Seeing none.
Thank you.
Thanks, sir. Next, Amy Campbell, Kansas Mental Health Coalition. Welcome.
Thank you, Mr. Chairman. This is my testimony, and I hope I've organized it in kind of a bullet point fashion so it's easy to get through. At the beginning, we endorsed the educational partnership that you heard about from the community mental health centers, the Center of Excellence. I want to talk for just a second about the Local Government Housing Security Grant Fund. We believe passionately that that money is very important, not only for the shelter beds that were discussed earlier, but also for something called supported housing units. Because if you talk about wraparound care, the things that really help people stay in a stable housing situation when they are folks who have serious mental illness that is recurrent, they need supported services while they're there. The success rates are very high. I highly recommend you could speak to our chair, Mary Jones, who runs the Mental Health America of South Central Kansas in Wichita, or Sue Lewis at Mental Health America of the Heartland, which is in Kansas City, who operate housing units like this. But the fact of the matter is we have many people with disabilities who receive housing vouchers for their disability, but there are no housing units to spend those vouchers in. And so they end up expiring. Moving ahead, we support the governor's recommendations for the State Housing Supports Director, but we would like to see you add the agency request for funding for the Behavioral Health Commission staffing for the CCBHC Mobile Crisis Response NFMH pre-litigation settlement agreement and the 988, that staff also oversees the 988 program implementation. We support the Family Support Coordinator position, the treatment costs associated with the family treatment courts, and the state institution building funds recommendations for rehab of the facilities. State employee pay, again, I spoke to you about that in the state hospitals budget. And then there is a bill in your Federal and State Affairs Committee about expanding the cap on lottery vending machine funds to fund crisis centers, and clubhouse programs. And we support Stuart Little's request for $5 million for substance use treatment. Thank you, Mr. Chairman.
Committee, questions for Amy? Seeing none, thank you. Next, Matt Fletcher. Interhab. Welcome, Matt.
Thank you, Mr. Chair and members of the committee. I'll be brief. I have 3 items that we would respectfully ask your support of in this budget. The first has to do with fiscal stability of the IDD system, and we've had wonderful conferees this afternoon talking about making progress on the state's waiting list for persons with intellectual and developmental disabilities. The members of Interhab wholeheartedly support moving forward in a strategic fashion to eliminate the waiting list. We hope that we are able to begin that process during this legislative session, but an essential piece of a strategic approach to eliminating the waiting list is to ensure the fiscal stability of the IDD system. You all made heroic progress over the last 4 or 5 years in increasing funding for the system. However, we still have not been able to establish regular, predictable increases for the system. This is critical if we're going to address a large human service challenge, such as bringing in 5,200 individuals into service, half as many as are already in service in the system. That's how large the goal is of eliminating the waiting list. So stability for the system, regular funding adjustments are a critical piece of that. We included in our testimony what an increase just based on last year's inflation, which CPI was about 3.4% last year, what that would amount to if you were so inclined to include that in your budget recommendations. The second piece that we would respectfully request your support of is employment services for persons with IDD. Again, if we want to make progress on the IDD waiting list, a large percentage of those individuals waiting for service are going to want a job in the community. So we have to start laying the foundation now for employment services. There's 2 pieces that I would like you to consider. The first has to do with a legacy program within the IDD system that is referred to as 14C. This is a program through the United States Department of Labor in which providers of service are granted these certificates, 14C certificates, that they utilize within workshop settings. It enables them to be competitive in bringing work into those settings so that they can provide the training for individuals they work with. 14C has fallen greatly out of favor at the federal level and will most likely be eliminated in the near future. We want to make sure that our providers here in Kansas who still use that tool will be able to successfully transition away from 14C. So we ask that you establish a fund for that transition effort so that providers can voluntarily transition away from the 14C tool. In order to do that, they need funds to enable the ability to pay the workers within those settings a minimum wage, and they also need investments in making those operations more efficient and more competitive, because again, if they're losing that tool that helps them to be competitive in bringing in work, they need some sort of ability to be more competitive when it's gone. The second piece has to do with supported employment. The governor put in an increase in her budget recommendations to take the current rate of $17.88 per hour to $28 per hour. We appreciate the governor's leadership in that regard. However, there's been a great deal of expert analysis done here in the state of Kansas over the last couple of years that points to a rate of $50 per hour. That's where we should be at. And in fact, if you look at contiguous states around us, their supported employment reimbursement is much higher. I refer you to Missouri, which is currently at $76 per hour. So we respectfully ask your support of those 2 pieces that will move employment forward for Kansans with IDD. My final request for you is to consider beginning restoring non-waiver state funds that were swept from the IDD system during the Great Recession. They were swept because they don't have matching federal funds, and the state was in a very serious financial condition at that point in time. We believe that we can make progress towards restoring those funds with a $2.3 million investment to start that restoration process. That fund used to be at $19 million. It's currently less than $5 million. That's how much was taken during that period of time, and it's never been restored since then. Those funds are used in your districts to provide for resources that can't be provided in any other way. So it might be assistive technology, it could be modifications to homes or vehicles, it could be to supplement other types of service needs that individuals or families need in order to stay in the community. And with that, I'll stop and stand for questions.
Thank you, Matt. Committee, do we have questions? Representative Carpenter.
So, Matt, I pulled those numbers on that. There's $4.6 million in there out of $5 million or whatever.
That's correct.
So, and when we're like 3/4 of the way through the year. So I'm trying to figure out how, do you save all your receipts and then you're going to spend that money between now and the 1st of July?
Well, we would hope that it would be in the beginning July 1st. That increase would be included for fiscal year 2025.
I'm talking about this year's funds. There's $4.6 million. You have not spent that.
Well, that would probably take us down a larger rabbit trail in terms of CDDO funding, and there have been holdups in those funds flowing out to the CDDOs. I'm not sure if this has to do with that, but some of it had to do with contracts getting through the internal processes at the state to be signed by all the responsible parties to get that fund flowing.
In the interest of time, we need to talk more about that.
Sure.
When I pulled it, and you're asking for that money, I pulled that fund. You're 3/4 of the way through the state, and you've spent $700,000. So
I will tell you, and I'm sure the department can speak to this in more detail, the CDDOs are required on, I believe, a quarterly basis to submit what are called taxonomy reports for the use of these services. And so those reports would be out there that you could request and see how the funds are being utilized in the community.
Mm-hmm. Any other questions? Representative Ballard.
So the rest, if I'm correct, is the $5 million for the 14C?
That's correct.
And then the 7.2 for the $50.
That would take the governor's 28 up to 50 per hour.
Okay.
Thank you.
And is that 7.2 million SGF?
It is. It would bring additional federal dollars into the state.
Okay. And Senate Bill 15 provided for $1 million a year for transitioning. Does that satisfy what your ask is?
It begins the process. We reached out to all 22 14C certificate holders during the last year to get an actual analysis of their workforce. There's about 1,000 Kansans with IDD who work within 14C settings currently. And in order to bring those individuals up to a minimum wage and provide the support on top of that for the providers, it would take $4 million in total, and $1 million was the beginning of that process through Senate Bill 15.
Very well. Committee, other questions? Seeing none.
Thank you very much.
Thank you much. Next, Sarah Hart-Weir. How'd you know?
I was reading the room and everybody's dropping like flies, so I figured I took a guess.
Well, fortunately, we have very comfortable chairs for you out there.
You know, we really, I was telling that to Representative Carpenter as we were walking in. Good afternoon, good evening, maybe. Sarah Hart-Weir, I'm the proud executive director of the Kansas Council on Developmental Disabilities. As you all know, our mission, working alongside our council members made up of self-advocates, family members, and other DD organizations from across the state, is to empower individuals with intellectual disabilities and their families and caregivers to lead systems change, build capacity, and advocate for inclusive, integrated, accessible communities where everyone belongs and thrives. I think you all saw that firsthand today in the testimony of several of our advocates, Dr. Marvin Miller, Catherine, Courtney, Laura, and many of our advocates that testified on Monday on the Senate side. As you can imagine, we're here to talk about the IDD waitlist and are advocating for funding to reduce that wait list by 20%. We were so grateful for Secretary Howard and the KDAD's budget request that included funding for 500 slots for the IDD waiver. We were pleased to see the forward momentum, I guess that was last week, with the governor's budget amendment to fund 250 slots on the IDD wait list. However, as we all know, the natural progression of the IDD wait list is about 200 to 300 individuals per the year. So that really doesn't get the numbers trending down, and that's where we want to see things. I know you've had a very long day, so I'm going to stop there and happy to take questions at the appropriate time.
Committee, questions for Sarah?
Thank you.
Thank you
very
all.
much.
Thank you.
Mike Burgess, come on down.
Well, thank you, Mr. Chair and members of the committee. Let's see if I can get this to stay up a little bit. Oh, all right, we'll make do.
It's floppy.
So, want to talk to you about a handful of things and build on some of the testimony from some of the previous conferees. We also want to stand in support of the Big Tent Coalition's recommendation to reduce or add new slots to reduce the waiting lists by around 1,100 on the IDD waiver and around 500 on the PD waiver. You can see the dollar amounts in my testimony there. Just wanted to kind of visually pull out a couple of things to build on that so you can see. I've attached to my testimony some documents that were prepared by Legislative Research. They did a great job of trying to take complicated things and really boil it down. So on this sheet, you can see the history of the two waiting lists. And unfortunately, you've seen them continue to grow as we get in the recent years. So I do want to point out, there were a number of years in there where the PD waiting list had there was no PD waiting list. It's been a little while since we've been there, but you can see, and then going back a ways here at the beginning of that chart, you can see that IDD waiting list was significantly less. And so it's our goal to get there. And I know there's a lot of work that the members of this committee and others have done to try and plan and figure out how we get there. And I know, so what this 1,100 represents is basically 1,100 and 500, roughly 1/5. And unfortunately, the waiting list has actually grown. The most recent updates, we're now up to 5,240, which is higher than what was in my testimony when I turned it in here just a few days ago. The PD waiting list is currently 2,271. And so we know that over the past 4 years, we haven't added any slots. And then we did one year, and then there were 3 years prior to that. So it's been very little growth in that waiting list capacity, and we want to do that. Another thing I want to point out, too, is, and you should have received this, there was a letter that a number of organizations signed supporting this effort, and I'll resend this so you have it, again, handy. But there's a very broad group of folks that are interested in this issue, as you know. So quickly to hit another piece, just wanted to talk a little bit about employment first and employment. And again, you've heard from other conferees. I want to echo their support. One of the things that wasn't mentioned today specifically is the NEON grant, a federal grant that KDAD's applied for and received. And we were able to bring in some national expertise. And they did a great job of trying to pull together, looking at both what's on the ground here in Kansas, as well as other states, and utilizing their expertise to put together some kind of shovel-ready recommendations for Kansas, which I've been working at DRC for 9 years. We've known the supported employment rate was low, and that has been a problem this whole time. We now have a report that talks about two things. So the rate is 1/2 of it, so I want to support that. Whether it's the 8.2 million I list in my testimony, which is the delta between what was funded by the governor and what the agency had requested to move that to $53. Another important piece is the service definitions. And that is what these individuals, the job coaches and the supported employment professionals, what they can bill for. We know there are a number of activities, or in the current service definition, they can only bill for time when they're actually with the client. And as you know, these jobs just don't fall from the sky. Individual job coaches have to go out and do job development. I was listening to a professional talk about this just the other day. When they have a client that wants to be a barista, they don't just sit down and call coffee shops for openings. This individual has to go to the coffee shop, they find out who does the hiring, they talk to them about shared employment and job carving and different things that can help match the strengths of their individual client with the needs of that employer. And this is just something that gets me really excited, because as we talk about the workforce crisis across the state, at the same time, we have the largest underemployed and unemployed group of individuals. And so it's time that we kind of put together and bring those together to help meet that need. Those are kind of a couple of things that I want to highlight. My testimony includes some other pieces. One other thing I just wanted to call out is the testimony of Lane Williams. And, excuse me, and he's talks about the NFMH case management services, and this was part of the agency request that wasn't, and that was part of the pre-litigation settlement. And so just wanted to encourage you to look at his testimony and endorse that 1.5 million funding for that NFMH case management. But with that, Mr. Vice Chairman, I'd be happy to stand for questions.
Committee questions. Representative Barth.
Is this the last one today? Are you the last? A couple more? Okay. Well, thank you. I actually am very visual, so I appreciate this chart here. I noticed here in 2021, both the IDD and PD, but specifically the physical disability numbers of people, like, was almost zero, and it jumped to, you know, in a year and a half to 2 years to over 2,500 people. What happened there?
So unfortunately, I will probably need to defer to the state agency. They would probably be better equipped as the program managers of the waiver to talk about that specific piece. So I don't know.
Madam Secretary, is there anybody here that can speak to that? You can get back with us. That's fine.
Yeah, I know it's late, but I would like to have that data, like, specifically, because do you guys track the reasons why they have a physical disability and why they're applying for it? Okay. And also, for both of them, actually would be good, because they both jumped quite a bit. Thanks.
Committee, further questions? Seeing none, thank you, Mike. Now, back to the chairman.
Linda stepped out for a moment, so let's skip down to Rachel Monger. Rachel?
All right, thank you very much, Mr. Chairman. I am Rachel Monger with Leading Age Kansas, the State Association for Nonprofit and other mission-focused aging services providers around the state, and I'm going to talk so fast. On the nursing home front, we are so incredibly grateful for the funding we received last year. When the new rates went into effect on July 1, I had providers calling me, some of them very emotional, about what that funding was going to be able to do for them. And I would actually point you towards some written testimony that I hope that you have from Sandy Klein at Production Valley Manor in Protection, Kansas, and she really goes through all the ways they've been able to use that money you've given us this fiscal year for their residents and their buildings. And it's really typical of everything we've heard around the state, and we are so incredibly blessed and grateful for what you all have done just in these last 6 months. Our most important goal now is to not move backwards. We have worked closely with Kansas Healthcare Association to create a budget request that promotes stability and long-term care. Our request on nursing home funding is really based on the fact that the 6.8% increase in the governor's budget recommendation that we're very grateful for isn't actually an increase from where we sit this fiscal year. It doesn't take into account our Medicaid capacity payments we're receiving. It leaves us with the same average cost of care gap we would have had this year without our Medicaid capacity payments, and it will take the average reimbursement rate in the state lower than where we are today. So that's why we're asking for both the governor's recommended amount for a nursing home rate rebase and PDPM adjustment, along with another one-year continuation of the Medicaid capacity payments that we are receiving this year and that have been so incredibly important and grateful in stabilizing our care. Next up is PACE. I'm very grateful Sean Sullivan was here to talk to you about that, so we support it and hope you will too. Last but not least is the frail elder waiver. Again, very grateful that Phoenix Home Care was here to talk about that, so I'm not going to repeat it. I would point you towards our case study and our testimony on Catholic Community Health in Olathe, Kansas, and they did produce some very good data for us on what their cost of care gaps on the FE waiver for serving people at home, and some of the drastic measures they've had to take in the last few years to try and break even. So as always, it is our ask that we find ways to further close the gap between Medicaid payments and cost of care across the long-term care continuum, and appreciate it very much, and I'm happy to answer questions.
Committee, questions for Rachel?
Yes.
Representative Ballard.
I was trying to figure out the ask. Okay. Thank you, Mr. Chair. I think I see 22.2 million in SGF, 1.9.
So the 22.2 million is, I believe, what's already in the governor's budget for our rate rebase. And then the Medicaid capacity payments, we got that updated number from KDADS, that's 23 million SGF. And then the 1.9 million is the last number we had on PACE for the 90% rate rebase, but Sean Sullivan earlier had gotten that updated number. That was, I believe, 2.4 million SGF.
Thank you. Thank you, Mr. Chair.
Other questions, committee? Now, the rebase is statutory, must be done every year, correct?
Yes, sir.
So is the 22.2 the statutory amount?
That is, from what we've been told by KDADS, that's the statutory amount for a full rate rebase plus a very small adjustment for switching to a new payment system that the federal government's forcing us to do called PDPM.
And if there's something beyond that, then the consensus caseload pretty much takes care of that, correct?
Yes.
All right. Other questions, committee? Seeing none. Thank you so much.
Thank you.
Linda Mowbray. Welcome to committee.
Thank you, Chair. I am Linda Mowbray, Kansas Healthcare Association, Kansas Center for Assisted Living. I appreciate you having the stamina to stick with us so that we can get this all done in one evening. I represent long-term care, nursing homes, assisted livings, Home Plus, the whole continuum of care. With our members, they were up here on the 1st of February. I hope many of you had an opportunity to have appointments with our members. They wanted to say thank you. The Medicaid add-on that you allowed for last year saved them. And after that money came in to their coffers, we haven't had a single nursing home close since that time. Prior to that, I believe it was 26 was the awful number that we were at. And that doesn't count the many, many that reduced bed capacity, weren't able to take admissions from the hospital. So truly sincere when I say thank you, and that money made a difference. We do concur with the governor's budget of $22.2 million, which is designed by statute to rebase us to the most 3 current cost years. And then, as Rachel had mentioned in her testimony, that did allow a small percentage for that adjustment moving from one payment method to another. So our first ask is that you would support the governor's budget on that. The second is, again, the Medicaid add-on. Whether we call it capacity or add-on, it's the same thing. It's trying to keep us with our heads above water while we figure out staffing and get the ship back up on right. SGF on that is 23.35, and then we do have the matching rates. So the all funds total is 60.9 million. The last ask that we have is for HCBS. And last year, you were generous with moving our rates for the frail elders from $5.05 per 15 minutes of care up to $5.55 for 15 minutes of care. We would ask a continuation of that 10% increase. Last year's cost was estimated to be 4.7 million SGF or 11 million all fund. We believe that it's pretty close to that as well. Some of the caseload has gone down a little bit, so even though it's moving things up, the numbers are down a little, so we feel that's really in the ballpark. I'll stand for questions. I won't stand between you and dinner.
Questions for Linda? Seeing none. Thank you very much.
Thank you.
We have one final in-person conferee. That's Leslie Anderson. Welcome.
Thank you very much. Mr. Chair, members of the committee, I'm Leslie Anderson. I'm the Executive Director of the Kansas Association of Area Agencies on Aging and Disabilities. I'm here on behalf of the 11 area agencies on aging, and I want to thank you for the opportunity for comments on the KDAD's budget. I want to briefly address our request for $10 million in SGF for core funding starting in FY25 and recurring. For 50 years, area agencies on aging have provided essential services and information to older Kansans and their caregivers. Other than nutrition, the most requested services are related to personal care and homemaker, legal services, case management, and friendly visits to reduce loneliness and isolation. Area agencies on aging are uniquely positioned in local communities to provide the support and services older Kansans deserve and need for optimal health. Dollars are spread a bit more with local partnerships, although with an average of 7% for organizational and expenses and administrative costs, AAAs are challenged to sustain their fundamental mission. We appreciate the strategic focus on aging mentioned by Secretary Howard. 23% of the Kansas population is 60 years and older. Growth is projected to be strong for every age bracket over 65, especially for adults 85 and older. Emerging trends of aging will be one of the greatest economic, social, and political transformations of our time. It will force changes in systems, have an impact on families, and will require new solutions. Aging in place will be a multi-generational event with numerous family members cohabitating and placing more responsibilities on family caregivers. The AAAs must scale up innovation and capacity to address emerging trends, including higher instances of unhoused older Kansans, behavioral health related to aging and loneliness, and more diagnoses of Alzheimer's disease and related dementias while people are living longer. The financial impact of aging will be massive enough that without funds to recruit and retain quality employees, implement continuous improvement processes, test innovation, become more efficient by utilizing technology and data systems, area agencies on aging will be adversely impacted and service gaps will widen. Core funding will mitigate this risk. We believe these funds are a wise investment to ultimately optimize the health, independence, and autonomy of older Kansans and their caregivers. And I ask you to add $10 million to the KDAD's budget for the area agencies on aging. Thank you. I will stand for questions.
Committee, questions? Seeing none. Thank you for your testimony.
Thank you.
I want to thank all the conferees today for appearing and for your stamina, as Linda phrased it. Thank you, committee, for your stamina. I want to thank our staff for this extra effort that they put in. And I especially want to give a shout out to Francie for coordinating all these documents. Oh, my word. So we got done. I will direct your attention to some written only testimony in your folder, and we will make our recommendations on Monday. So we are adjourned.
Mr. Chairman, I have a question.
Yes, I adjourned. I'm kidding. Go ahead.
Megan provide us with a summary document like she did so well for our last budget?
Yes, yes, Dayton will work on that, and he'll have it by 6:30 tonight. I'm kidding. No, he'll have it tomorrow.
Thank you.
Thank you.
Thank you very much. Good night.
Okay, we are adjourned.
Kansas.